Hello, everybody. I hope you had a great time during the lunch break, and I hope you enjoyed the exhibition. I am Carole Brückler, Head of Digital Health Technologies at the Ministry of Economy, and I will be your Master of Ceremony for today's afternoon, the Digital Health Afternoon at the Digital Summit. In the next few hours, we are going to spend together. We will discuss a particular topic dedicated to embracing innovative collaborations to solve healthcare's greatest challenges. An amazing lineup of speakers will take the stage to discuss, amongst other things, how to forecast the next pandemic, how to build resilient and sustainable digital infrastructure, and so much more. As ICT Spring is supported by the Luxembourg government, and I am pleased to launch today's afternoon with a message recorded by our Minister of Economy, Minister Franz Fayot. Let's discover together what he had to say.
Good afternoon, ladies and gentlemen. It is a great pleasure for me to welcome you to this Digital Health Afternoon, part of the Digital Summit here at ICT Spring. In Luxembourg, this is the first time that health and digitalization in healthcare are addressed in a large-scale IT conference like ICT Spring. This clearly shows how strong and important the link between digital and health has become. Over the past year and a half, we have all learned that there is nothing more precious than good health. The difficult supply of surgical masks and other medical equipment at the beginning of the pandemic also has shown us how value chains for healthcare products are dynamic and global, and thus how critical they are for the functioning of our society. Lessons were learned from the pandemic, its impact on every one of us and on our economy. All this invites us to build a more resilient society. We also realized how digitalization made available the necessary clinical data to navigate through the course of the pandemic and respond to the crisis. And I look forward to hearing today how we could do more in this matter. As a vision and path forward, the Ministry of Economy developed a roadmap for a competitive and sustainable economy for Luxembourg under the title Ons Wirtschaft voor morgen, our economy of tomorrow. It addresses the industrial innovation policies, regulation, financial instruments, and actions necessary to support the emergence of a more resilient economy, facing the challenges of tomorrow, highlighted also by the pandemic. Digitalization is a key pillar of this roadmap towards a more resilient and sustainable economy. Today, thanks to the potential of digital technologies, such as AI, understanding of genetic and genomic data, reusing anonymized medical data from electronic records, computing power offered by supercomputers, we are living through a period of true medical revolution. By putting cybersecurity at the heart of the development of its digital infrastructures, Luxembourg will be able to position itself as a leader in terms of trust in its health data ecosystem, unlocking the value of health data in the interest of patients. Medical innovation based on new digital technologies will further create a medicine that puts the patient at the center of his healthcare. Whether it is a personalized treatment plan to fight off an existing illness or preventing getting ill in the first place, the contribution of digital health technologies will only grow. This emerging field of digital health requires true collaboration and the whole network, from innovative companies to researchers and to clinicians, all of them supported by institutions. It is exactly this environment that we want to further develop here in Luxembourg. A particular opportunity exists to strengthen the local industrial value chain in the field of molecular diagnostics by capitalizing on the presence of key private and public actors to constitute a value chain from innovation to the market. The ultimate objective of generating a sustainable supply chain in terms of diagnostics is one of the pilot projects in our Economy of Tomorrow roadmap. All those developments and projects fit perfectly well with the theme of today's conference, embracing innovative collaboration to solve healthcare's greatest challenges. You will hear how the Ministry of Economy plans to set up a national data exchange platform that will provide new opportunities regarding health data. You will also get an insight on how Luxembourg is contributing to the Gaia-X project to build a reliable data infrastructure for Europe, where data and services can be made available, collated and shared in a trustful environment. We also have much to learn on how to make adoption and use of new technologies easier for patients, doctors and healthcare institutions to ultimately put patients at the center of their care. All this without compromising trust in the quality of care, the safety of products, and the security of our health data. Ladies and gentlemen, I would like to thank all of today's speakers for the time they have taken to join us and for their valuable contributions to advance our thinking. I also would like to thank the conference organizers for putting digital health in the limelight at this year's ICT Spring Conference. Finally, I would like to thank you, visitors and attendees to this event, for your attention and your will to contribute to building a better, more resilient society. I hope that you will spend an insightful and inspiring afternoon.
Without further ado, let's start the conference with our first speaker, Dr. Sylvie Briand. She's currently director of the Infectious Hazards Management team at the WHO Health Emergency Program in Geneva. Her department is responsible for developing mechanisms to address epidemic disease under the international health regulations to reduce their impact on populations. She was previously the head of influenza management during the H1N1 pandemic and has worked on cholera and yellow fever. A very impressive track record, if I may add. So in the frame of the Digital Summit, she will discuss how to predict the next pandemic. Surely a tall order, but we look forward to hearing what you have to say. Can you hear me, Dr. Briand? The floor is yours.
Yes, I can hear you very well. Thank you so much. And thank you very much for inviting me for this very interesting meeting. I'm very happy to be able to talk today about pandemic, although I've been living in a pandemic status for more than 1 year, of course, because at WHO we have been very much involved in this COVID-19 pandemic. So I would like to share my screen if I have the possibility, please. Thank you very much. So, thank you. Can you see it? Okay, so I hope you can see my screen, and really what is important with pandemics is that we will have a next pandemic, that's for sure. And the question is not if, but when. And we have also other questions, of course, because we want to know where will it start, how severe will it be, and who will be most affected. So these are the key questions that we need to answer if you want to really forecast pandemic. And this is just to show you what has happened since the beginning of this century. And you see that we have had many epidemics with the pandemic potential. We had SARS in 2003, H5N1 in 2003 as well. Then we had cholera, H1N1 in 2009, Ebola, MERS, plague in Madagascar, Zika in Brazil, and 60 more countries, yellow fever in Central Africa and in Brazil as well, and so on. So basically every year we have an epidemic with pandemic potential, but fortunately not all epidemics become pandemic. And currently in this century, we had only two major pandemic. One is the H1N1 influenza pandemic in 2009, and the second one is, of course, COVID-19 that we are still in. And why we will have more pandemics? Because we are more people on Earth living in more densely populated areas, and we have more mobility. And so these create the factors that drives more epidemics and also the risk of more pandemics. And just to tell you what is really important also to consider is the severity, because we have had many pandemics, but they are not all severe or as severe as, for instance, the 1918 Spanish flu, which we are not able, of course, to know exactly the number of deaths, but it's between 50 and 100 million deaths. But other pandemics in the 20th century were less lethal, and we had between 1 to 4 million deaths. And the last one in 2009, actually, the world was very well prepared, and we managed to maintain the number of deaths below 500,000. So I think the message here is that it's not because it's a pandemic that it's necessarily a chaotic and crisis. You can also get prepared, and this is why forecasting them may help pandemics. Usually you have the emergence, and this is what we have seen with COVID-19. The virus came from an animal, and we don't know yet which animal, but what is for sure, it's a zoonotic virus. And then it started to infect human population. So at the beginning, you have few cases, but then you have a localized transmission, and this is what happened in Wuhan, for instance, in December and January 2020. And then you have the amplification. It's when it spread, whether in the same location or beyond this country and or this continent to the entire world. So this is when we have pandemics. But after some time, because of the immunity we acquire, or because of vaccination, you start to see reduced transmission. Sometimes we can eliminate the problem, not the disease, but the problem at least. Sometimes we can eradicate the disease itself. It has not happened very often. Only smallpox was the disease that has been eradicated so far, but we don't know. We may be able to eradicate more disease in the future. So at each phase of this dynamic, you have the possibility to intervene, to detect earlier, to stop, to contain the outbreak or the epidemic, and to control the risk in the long term. So this is just to highlight how it has played out so far with the disease we know. For example, in H1N1 2009 pandemic, we went through the pandemic phase, but then we are now seeing a reduced transmission. Many people on Earth are already immune, either through vaccination or through natural infection. And this is why now H1N1 2009 virus is becoming endemic and just creates seasonal epidemics. Ebola in 2014 went to the expansion also, but we see now a reduced transmission. We have a vaccine and we have treatment as well. MERS, on the contrary, just remain creating localized outbreak, and we have not seen yet large epidemics or pandemic. And COVID-19 we are in currently. So we have created some tools to be able to better monitor the risk. For example, we have a system that search information in open source data, and we can detect signals of outbreak very early on, which allow us to respond quicker to outbreaks and epidemics. And we have also developed some tools to predict somehow when we will have the next outbreak. Currently, with this tool is a pilot tool. We have developed it for cholera, and it allows us to predict when the next peak of transmission will happen, and to see if the region or the district where it may happen is ready, has enough chlorine or vaccine to cope with the outbreak. So this is thanks to South Sudan and many partners that we have been able to develop this pilot tool. We hope in the future to be able to first include in the tool more disease, malaria and other recurring disease, plague and so on, and also have something that can be used in many more countries, and even in the near future have a global forecast like what we have for weather forecasts. But for this, we need good data to put in the tool, because otherwise, for modeling, garbage in, garbage out. So if you don't have enough good data to put in your model, then you don't have a good forecasting or prediction. So what we need is, of course, increase the capacity to collect those data. And one example is, for instance, what we have done on laboratory science and diagnostics. Now we are able to detect much more rapidly pathogens, but also thanks to digital tools, we can transmit this information much faster, and we can also analyze large data sets in a record time. So all of these innovation will help us, of course, to do better forecasts. And I want to highlight here the fact that we have launched last week the Berlin Hub. It's a WHO hub for pandemic and epidemic intelligence. And we hope that it will allow us here to connect worldwide researchers, scientists, and developers of tools, so that we can have better tools for monitoring the risk, the ongoing risk of epidemics, but also even develop this forecasting tool for epidemics. My last point is really on the other side of epidemics and pandemics. Everybody is focusing on cases and death, but actually a pandemic is a social event as well. And as you know, it has disturbed a lot our societies, and it's really a disrupting event. And one thing that is really important with epidemics or pandemics is that it's characterized by a lot of uncertainty and a lot of fear. And the two goes together. But so these factors are really important also when you manage epidemics and pandemics. And with fear, with uncertainty, comes a lot of rumors, a lot of information that is circulating among human population. And we see this with every epidemic, every pandemic. It's not specific to COVID-19. And for Ebola or for other disease, plague, we always have seen a number of rumors, whether it's on the treatment, on the disease, or the cause of the disease, or on the intervention that are put in place to try to control the epidemic. And so, but what has changed with COVID-19 is really the way the information is produced, distributed, and consumed. And you see on those two pictures how things have evolved. So now you can be connected very rapidly to millions of followers, and millions of people will receive the information in a real time. But sometimes this information is not necessarily accurate, and it can lead to really not accurate also behavior, not healthy behavior, and people make a wrong decision for their health. So that's why we call it an infodemic, which is really an overabundance of information. And with the virtual space, of course, it has become more challenging to manage it properly. And so this is why we have developed tools to do that using digital technology. But it's very important to understand that even if infodemic is not a viral, it's not a virus, a biological entity, it still can harm health. And we have seen that some misinformation can lead to confusion, risk-taking, harmful behavior. And for instance, in Iran, at the beginning of the pandemic, there was this rumor that methanol could be a good cure for COVID-19. And because of that, 700 people have died, 5,000 have been hospitalized, and 90 of them have had long-term sequelae. So I think it's very important to really take into account this infodemic phenomenon that accompany each epidemic and pandemic, so that we can better manage it in the future. And we have developed, for instance, a tool to listen to population concern, because it's very important to understand what matters for people. And this tool enables us to understand what are the conversations on social media, what are the topics people are interested in, try to understand if it's different between countries, if this topic is rising or decreasing, and then we can also assess if it's more a conversation of men or a conversation of women, because it has an impact also on the way you will then message the advice for people to take better care of themselves and their families and their community. And so again, listening is absolutely key. And this is where digital tool can help us much more to listen to people. Thank you very much.
Thank you, Dr. Briand, for bringing your expertise to the field and insightful how everything is connected after all, especially when it comes to digital. The next presentation is entitled Building Resilient and Sustainable Digital Infrastructures and will be presented by a member of the Luxembourg Gaia-X coordination team. He is also Digital Acceleration Lead at Talindus, where he is working on future technologies and innovation topics. And please give a warm welcome to Ralf Hustadt. Ralf, please join me on stage.
Yeah, good afternoon. So linking into the topic we just had, my topic today is building a resilient and sustainable digital infrastructure in Europe. I know the topic sounds really, really dry, but I'll try to make it as interesting as possible. So before we really start, I would like to take a look back into time. So going back slightly more than 50 years, it was the time when commercial flights were really picking up. And it was dominated by a few US companies. Basically what we saw is, we saw Boeing, we saw Douglas, and we saw as a third company Lockheed. The only European planes at that time were the French Caravelle and the BAC 111, which were almost at the end of their lifespan. When the companies actually realized that, they thought, we have a serious issue, because none of the aerospace companies in Europe had actually the money and the funding and the resources to shoulder the invention and the setup of building a new airplane. So Europe was about to seriously fall behind. Some companies actually realized that, and they kind of sat together, and in 1969, the governments of France and West Germany signed an agreement which, well, resulted and paved the road for GIE Airbus Industries. GIE, if you're not familiar with the term, that's a French expression. Basically, it's a set of companies, and it's usually used for large construction projects, multi-stakeholders that actually kind of sit together and decide on, yeah, let's do something together. Airbus, well, the rest you know probably, or is history. Airbus took care of all the central components, they took care of the design of the airplane, they took care of the marketing, they took care of after sales and all these things. But actually, all the fabrication was done by all the different companies that were part of this consortium. And if you look at it, well, eventually it led to quite some orchestrated engineering projects. So I just heard that in the background, the A380, last one of Lufthansa, is now parked safely in Spain. But hey, you never know how things are going. So, fast forward to today. We know data is the new oil. At least everybody knows that who has not hiding in a cave for the last 10 years. So what's the new story there? Tell us something new. Okay, well, the business has changed, but actually the underlying principles of doing business are quite similar to what happened over 50 years ago. So history is repeating itself. And that was also addressed, or that's all what we see with the platform economy. So it's largely dominated by the US, a little bit in Asia, Europe 4%, and not all of the companies that we have over here are actually bound to be successful. Same thing with the cloud market. It's growing year by year at a massive rate, a couple billions. And again, it's dominated by foreign companies. Again, we're falling behind. And that was actually also realized, and this idea is also shared, and perception is shared by the European Commission. And exactly 1 year ago, so in her last speech, Ursula von der Leyen addressed that one. And she said that a real data economy would be a powerful engine for innovation and new jobs. And this is why we need to secure this data for Europe, and we need to make it accessible. We need common data spaces, so this is not only about technology. This will all support innovation, and well, everybody should be able to access and collaborate on data. What's not explicitly mentioned in her speech is that we also need a common infrastructure, we need common rules to play by, we need standards, we need compliance. So there's a lot more to the whole thing than just some technical setup. If we don't actually keep the governance and on our data, we risk losing the sovereignty. And the opposite of information is not just the absence, but it's actually that somebody else controls the data, and then you're really into problems. We saw that at the previous presentation. It's all about data by now, even if you're talking about health. So the idea is, how can we actually set up such an ecosystem? Right now, the situation is, that's what we see on the left side, is the user can more or less choose one platform. Choose your flavor. There are a couple ones to choose from, but it's a one-way street, and it's very hard to get off again afterwards, and it's also very hard to cooperate and collaborate with other parties. So the idea is to shift into an ecosystem where you actually have multiple providers, and you can rest assured that you can collaborate, that you can freely move between those, that you can work with other parties who might be on another platform. So, how do you actually build that one? If you start with a blank page, and you're already a couple years behind because, well, let's face it, there are companies in place that actually run that stuff. So, first thing you need to do is you need to figure out what are your requirements. And at that stage, enter stage Gaia-X. The mission, we aim to develop a common requirements for a European infrastructure. Please note, this is not we built the platform. That's a difference to the GIE of Airbus. Right here, the idea is we start with a set of requirements and let's see who actually all contributes to that. So what is Gaia-X? Because some might have heard that, some might have seen that, but it's very vague and it's already sometimes negatively connoted already. So what is it? Actually, Gaia-X, there are some important key points and values. So the vision is access and share data. That's the highest priority. That's the idea. The objective, of course, because it's a commercial undertaking, it's about the growth of a digital ecosystem, and because it's a European initiative, it should be surely based on European values, regardless if this is values which are already ingrained in law or which are just based on culture. It is a European cooperation. That is very, very important because there are also some players from abroad who actually contribute to all this thing, but they need to play by European rules. Then we have, which directly links into this, is transparency. We don't want to have something that is a black box that, well, I take my data, I take my health data and dump it on this platform and, well, I get something out afterwards, but I have no clue how it works and nobody really tells me. So it doesn't explicitly state open source, it states transparency. The last two topics, security, right protection, so I hope everybody can see that. These are also topics which are gaining in importance, especially for the last one. You know, everybody by now should know the meaning of GDPR and how you actually have to implement that one. So, who is all in there? That's the next thing. We have 3 layers on the whole thing. We have on top the data ecosystem, so that's the parties who are actually contributing with data to this whole thing. In the middle, we have as the blue, the federation services. That's more geared for software, providing something that you have to have when you want to process your data. And of course, on the bottom, because it's IT, and IT eventually needs some sheet metal to run on, it's an infrastructure ecosystem. So who are the bodies that actually play a role in this thing? The organizational structure is set up by 3 different, let's say, larger groups. So one is the IESBL. That's an international association that does not have any profit interest. So that's more or less the centralizing, that's the sun in the little universe that we have over there, or in the ecosystem that actually puts things together. It's fairly young. It's just been set up in Q2, so this is really growing fast. Its board of directors is 24 people from large companies mainly, so big players, which also underlines that it's taken seriously by the members. And the real work actually happens in the different committees. So you have a policy rule committee, you have a technical committee, data spaces. By now there's also a label committee, which was not out there by the time I made the slides. Just happened to have a talk with them on Monday. So the second body, that's where I'm also working in, that's the Gaia-X hubs. They're just springing to life. The Luxembourgish hub is taken care of by Lux Innovation. And well, the setup is different from country to country. Germany and France were the first ones to come up with something. We were in the group that followed quite fast. Right now, there are also countries that have established something but not formalized it. Other companies have full-time employees doing that. So the key message for the hubs is it's growing fast. And last but not least is the Gaia-X community. These parties are all the parties that actually run projects. That's the coalition of the willing, so to say, who want to do something in Gaia-X, who want to use such a data space, who might have a tool that they would like to use. They're not necessarily a member of the IESBL, because that's a different role. So everybody can be part of the community, everybody can use and contribute, but the function of the IESBL is slightly different, and I'll actually show you now how that all works after showing that the association setup. So you see it's not only the big ones, it's also small companies, NPOs, non-profit, medium. So the setup is quite like this. So how does it work? As I said, you have the IESBL with the different committees. You have the Gaia-X hubs, and they actually form a matrix with the different domains. Of course, there are slightly different interests per country. Every country kind of has picked its favorite topics. So for example, let's say the automotive cluster is more attractive or more interesting to the German side than to the Belgium side. Luxembourg has, for a very specific reason, and you see that in the next presentation directly afterwards, so stay tuned, has the lead in health. What exactly do the hubs do? So there are some parties, let's say, they are interested, they have a common interest marked by the color, and they want to say, hey, I have a tool, I have a data space, I have an idea, I want to do something, and I definitely don't want to do it in a public cloud. We as the hub team, we actually bring those parties together. We do that either on national level, or we do it on international level. Or as Peter Soderman said, we are the Tinder of Gaia-X projects. Next thing is that you actually have these projects being run by the different parties. So think about somebody just invented the combustion engine, and somebody says, hey, you know what, wouldn't it be cool to have a car? So they kind of sit together and they build a car. And another project team might build something which is like a motorcycle or a truck. Now, besides building these things, of course, when they sit together, they also need to think about the requirements. Notice, requirements, that's what I said, is the aim of the ISBL. So they kind of note down the requirements. Somebody says, you know, wouldn't it be nice to have some light when we drive at night? Front light, yeah, wrote that down into the requirements. So he puts that into the requirements. Somebody else says, oh, backlight, yeah, should have a different color, right? Yeah, let's make it red, put it down into the requirements. So they all produce these requirements, and of course for a car, for a truck, and for a motorcycle, they're slightly different, but there are probably a lot of similarities. So these eventually flow into the IESBL, into the committees, which does a dissemination of all these things, a clustering, a regrouping, a discussion. That's actually the core functionality of the IESBL in the committees. Note, for the projects and for the participant in the projects, you don't have to be an IESBL member, but if you want to have a saying into what the IESBL produces as a specification, and that's their output, you need to be in the IESBL, you need to be a member. Pricing varies depending on the size of the company. So they actually propose standards. They don't really produce standards because that is something that only the standardization bodies can do. And there would be jumping directly on the table or say, this is the new standard. No, you can only produce specification, but no standard. So that's what they actually propose. And eventually this will go into a label. And that one, you can, if you see that label popping up, you know this is based on all the values of Gaia-X, and you can freely work with the other players. So, what's in it for you? Why should I do this? My boss is asking me, why should we do this? So there are actually two things. One thing is, in the long run, you can store your data on a Gaia-X compliant cloud. You can keep control over your data. And yeah, you can share your data with other parties. If you join now and actually participate in such a thing, you can discover new business opportunities. You can also shape what Gaia-X will be like. And who knows, maybe in 20 years, you will tell your grandkids, hey, I was part of the game. So if you're interested, there are two ways. You can either reach out directly to Lux Innovation, because they're driving this whole thing as the central place over here, or you can contact directly the coordination team, which is linked over here. And if that was all too fast, you might just want to copy the QR code, because that leads you to our contact page. With that, I'm done. I hope I've stuck to the time schedule. If you have any questions, I'll be around afterwards. Thanks a lot.
Many thanks, Ralf, for joining us today. It was a pleasure to have you on stage. Very insightful, a lot of work ahead of you as well. Before our upcoming advertising break, I would like to warmly introduce you to our next speaker, who will be discussing Clinova, which is a transnational digital health effort that is unlocking the potential of AI and data science in healthcare. It's a tall order. I'm very pleased to introduce you to Jasmin Schulz. She is the program director at the LIH, the Luxembourg Institute of Health, leading this project in Luxembourg. She holds a doctorate in clinical medicine from the University of Oxford, has worked in medical communications, was a project manager for the Genome Project in the UK, and she was responsible for organizing the large-scale testing in its first phase. A lot of impressive projects behind her, so she's more than ready for the one that awaits her now. Please join me on stage, Jasmin, and then we'll hand over to you.
Yes, can you hear me with the mic? Okay, it's fine, right? Yes, good afternoon, everybody. Thank you very much for the introduction. It almost feels a little bit strange to be back on stage after 1.5 years of online meeting, but it feels good, and I hope we can continue organizing meetings where we can physically meet and interact. It is a pleasure to be here today and to present you the Clinova initiative, which aims to unlock the potential of data science and artificial intelligence in healthcare, and its link to the Gaia-X initiative that Ralf just focused on in his talk. To start with, I will give you a little bit of background. We know that big data, data science, artificial intelligence has already brought about change to many sectors. The healthcare sector has lagging behind so far, which got a boost to the pandemic, if you so want to say. And in the sooner or longer term, data science, big data, artificial intelligence will also transform the healthcare sector. And we really have to be on board now. We have to navigate this paradigm shift in order to enable innovation in healthcare in Europe. And recent data show that over the next 10 years approximately, overall healthcare expenditure will decrease per person, but within these decreased budgets, there will be an increase for investments into personalized healthcare, digital health, precision medicine. And the biomedical research sector has to follow, will have to impact and focus in the future on related topics such as personalized medicine, smart diagnostics, precision medicine, and disease prevention. And this is exactly where the International Clinova Initiative would like to come in. As I mentioned at the beginning, the aim is to unlock the potential of data science and artificial intelligence in healthcare. And we believe that we will achieve this goal by starting at the source, by starting at the core, meaning that we aim to create a data-enabling environment, but we do not want to create an empty shell, an empty data architecture. We want to fill this architecture with meaningful data, and we want to achieve this by defining a focused number of disease use cases around which we can then start building this data architecture. Currently, we have a number of countries already participating. We have Luxembourg on board. We have the northeastern region, Grand Est and France, and the southwest of Germany as participating countries. And we also have interest from Switzerland and also further afield, for example, from Canada and from Japan. In Luxembourg, we do not only have buy-in from the research landscape, mainly the University of Luxembourg and Luxembourg Institute of Health, but also from the major healthcare stakeholders in the country, the hospitals, the Ministry of Health, the CNS, Agence et Santé, but also the Ministries of Economy, Research and Higher Education, and the FNR, the National Funding Body. As I said, we aim to define a number of specific use cases that we can then use to build a data architecture around. We have defined these use cases together with the international partners, and we will focus on complex, chronic, immune-mediated diseases, namely inflammatory bowel disease, rheumatoid diseases, and multiple sclerosis. These diseases affect a large number of patients worldwide and have a rather large market. And in addition to being immune-mediated diseases, these conditions have in common that a large number of standard of care drugs are already available on the market, but it is very difficult for treating physicians to define which drug or which treatment will work best for which patient at what time. And here Clinova would like to contribute, would like to help support the treating physicians who take part in Clinova by trying to better understand the patient on a holistic level and thereby trying to better subgroup these patients based on their profile into subgroups, and hopefully by this being able to better define which patient may respond to which treatment. This being said, meaning we will start with a prospective cohort of patients, we will obtain or collect new data that will be of high standard, that will be quality controlled, that will be interoperable, and we will use these newly collected data for data science and artificial intelligence approaches. But in the long term, we also aim to feed in retrospective data from existing data sources. Also, in terms of biomaterial, we try to follow a standardized approach as much as possible. At least in the early phases of the project, samples coming from all participating sites will be processed in Luxembourg, and here the Integrated Biobank of Luxembourg will play a central role. In terms of data collected to obtain a holistic view of a patient, we try to step back from a pure omics approach. Of course, omics data like genomics, proteomics, transcriptomics are very important data, but we would like to also look into additional data sources, for example, the profiling of immune cells or digital markers like voice or movement profiles. And we would like to integrate these data, analyze them together in a multiplexed AI-driven approach, meaning that we will not only look at certain data sets in isolation, for example, not only genomics, but we want to integrate all these data sets and hopefully identify small but significant changes, which will then help us to better subgroup patients. Now that we have defined the use cases, let's go back to the data environment. Of course, the data structure that we will build up will comply to high cybersecurity standards and will also comply, of course, to GDPR, which has been implemented a couple of years ago. And our overall goal is to create a federated data environment, meaning that in the course of this project, we will not establish one central data warehouse in which all data from all participating sites will be stored. We will rather have local data integration centers, meaning that the data will stay at the site where a patient has been recruited, and that analysis in the long term will be able to be performed remotely. This is, of course, a challenge at the start. This will take time, but this is our ultimate goal. Central for the Luxembourgish partner site will be in this regard the creation of a data integration center here in Luxembourg that will initially be built around these use cases, as I mentioned, with the university and the Luxembourg Institute of Health as research partners. But in the long term, we hope to also reach out to the healthcare stakeholders in the country, like the hospitals, the Ministry of Health, and the CNS, in order to enable further patient-centric research to really enrich the data sets that can be available for research and to really boost patient-centered, real-world-driven research. The impact that we foresee is, we call this a clover-leafed approach, in which Each region, in theory, would be independent and sustainable on their own, but of course by combining efforts, by allowing each participating sites access to the material and the data obtained from all sites, from all partners, will of course multiply the initial investments. And we do see Clinova as a nucleation point for further collaborations with the private and the public sector. And this can of course also attract the venture capital and support spin-offs in the field of precision medicine. So how is Clinova linked to Gaia-X? As Ralf mentioned in his talk, Luxembourg currently holds the presidency for the Gaia-X Health Working Group. There is a working group for each sector in Gaia-X, and due to the Clinova use case, we were offered the presidency for the Health Working Group, which we will hold for 6 months until early 2022. And we will support Gaia-X in informing itself by streamlining the health community into working groups and defining use cases and supporting the mission and vision of Gaia-X. So for one, we will try to integrate more national hubs to really create a health community in Gaia-X. And secondly, we will also try to define trans-European collaborations to really underline the European spirit of Gaia-X. A large number of use cases have already been proposed, which can be found on the Gaia-X website. And together with a small coordination team that we are currently setting up with partners, European partners of Gaia-X, we will assess if some of these may be eligible or may be suitable for a trans-European approach. And we will also allow the community to propose new European use cases. These use cases should then really highlight the requirements that are needed on a larger level to define a common data architecture, common data access, common data sharing modalities. And of course, we should try to make use of existing use cases, for example, like Clinova's proof of concept, but we should also make use of these use cases to advertise on the European level to allow further funding into these Gaia-X use cases. Therefore, we define use cases in 3 categories: use cases that are existing and funded, use cases that have been formed but have not been funded yet, and use cases that are in the process of being formed that will also need Gaia-X, further financial support from Gaia-X ideally. So once we have defined about 6 trans-European use cases together with the coordination team of the Gaia-X Health Working Group, we will set up working groups that transcend these use cases, as all of these use cases in the healthcare sector will have to work on similar topics like interoperability, IP valorization, communication. And the aim is really to set up working groups containing members from the countries that have proposed the use case, specialists in the field from the community, but also members from the ISBL for direct feedback, basically from the central body of Gaia-X. And the overarching goal is the same in analogy to Ralf's presentation, would be to define requirements, to define specifications that we would need in order to set up this common data infrastructure, which can then be fed back into the ISBL for further policy procedures and policy documents from their side and technical documents from their side. And with this, I would like to conclude. I would thank you very much for your attention, and I will also be around during the coffee break should you have further questions. Thank you.
Putting the customer at the center of everything we do is the new mantra within our organization.
We want to make experiences as frictionless and seamless as possible.
And we still want to make sure that people feel the human aspect of our business.
You don't want a customer to know that you're a series of different departments. They want to know that they're talking to T-Mobile.
Salesforce enables our colleagues to do what they do best, which is build that relationship with our customers.
The beauty of the Salesforce platform is it gives us a 360-degree view of our customer.
When you're on a single system, everybody in the company can have a single view into the customer lifecycle. you can really create an amazing end-to-end journey.
It's smart integration. Our rate of innovation has increased with the Salesforce platform because we're able to try things new very quickly, and if they don't work, then we go back to the drawing board.
We have the ability to change direction if we need to, because there's data there that is real time.
And then we move to the predictive insights. And that's what we need to run our business.
So right now, we can actually get the true power of being a global company by using Salesforce technology. It's, super exciting.
The fact that we have one system rolled out globally is enabling us to innovate and execute in a way that we never could have done before.
Salesforce ci ha trasmesso una sicurezza che i dati dei nostri stimabili, amabili clienti vengano in qualche maniera rispettati.
Salesforce has been a guiding light, showing us what is possible when you platform everything around the customer.
Certainly, customer expectation is one of the key pressure we have to deal with. They want simplicity, they want peace of mind, they want digital services, and for the insurer, it's still the beginning of the transformation journey. So with this new infrastructure, we really change the performance and the availability of our operations. AXA is one of the oldest insurance company on the local market, and we are active on all lines of business. And I would say we are really at the beginning of a fantastic transformation, not only on the local market, but also the insurance business is really transforming every day. If you want to provide quality of service to your customers, to your agents, to your employees, performance is really key. With the former infrastructure we had, high availability, for example, was not at the level we expected. Because when people in 3 clicks, they can have everything they want delivered to their door the next day, they probably expect the same from their insurance companies. Why to choose Dell and VMware in our context? I mean, first of all, because we are relying on our partner to propose the best solutions in our context. This new software-defined infrastructure was really answering to the needs of flexibility, to the needs of high availability, and was reducing the cost. If you engage with a partner on technology for a couple of years, you need to be aligned on the objectives, on the innovation, to share the same vision. So I went to visit the entity office, and it was a bit like in the AXA office. People were talking, moving, collaborating. So it was the right balance between skills and the ability to execute, but also the culture, the trust that you have, and a common vision. We divided by 2 the time to run some processes. We divided the time by 3 to do our backups, for example. We wanted also to simplify our operations, to really have more standard platform, which is easier to maintain, to improve our time to market. I'm convinced that the future will be hybrid. Hybrid meaning local and in the cloud. And the insurance industry is still, because of our regulatory context, still at the beginning of this cloud transformation journey. So with this new hyper-converged infrastructure that we have, we are ready to operate an hybrid model. And this hybrid model will be made of local services, probably services provided by the group, but also provided by a couple of partners that we will need to provide new services to our customers. So we will need to connect to an ecosystem. And this new infrastructure will really facilitate this hybrid model, both hybrid on infrastructure, but hybrid as well on the ecosystem that we will operate. So this infrastructure, it was key also to prepare this future.
Great. Let's continue with our next expert. So I have for you Leesa Soulodre, who is a Xennial deep tech pioneer, speaker, educator, mentor, and general partner of R3I Ventures. As a Xennial, born in an analog childhood and a digital adulthood, Leesa is a serial entrepreneur that has invested her lifetime on the frontiers of deep tech, pioneering digital transformation and innovation. She has served for more than 400 multinationals in consulting and a plethora of startups across Europe, Asia, and the Americas. Today, she will talk to us about unlocking transformation to value-based healthcare through global innovation partnerships. We are connecting to her right now. Leesa, can you hear us? Wonderful. The floor is yours.
Good morning, good evening, and good afternoon. It's my great pleasure to be with you here today at ICT Spring. My name is Leesa Soulodre. I'm the general partner of R3I Ventures, and we have a mission. We would like to save the planet one startup at a time. Did you know that nearly 7 centuries ago, in the mid-1300s, the first major outbreak of the bubonic plague forced Europeans out of their homes, much like today, into the worst social distancing measures ever seen in history. And in fact, in 1353, these hysterias were just so extreme that brother abandoned brother, mother abandoned children, and people just discarded others as if they were not their own. When people sensed the worst was over, they slowly came out of their homes. But there was no grand reopening of the economy like a department store. People remained highly mistrustful of one another, continuing to avoid even the most basic of social interactions and engagements with their professional colleagues. And just when it seemed that the situation was finally starting to get better, the plague struck again in 1360 and again in 1374. Medieval Europeans quickly realized that there was a single rat left on the planet. Then another wave of the pandemic could begin anew. And that made it next to impossible for the economy to go back to normal. But I feel very optimistic. And I feel very optimistic because today we have issued for every 100 people in this room a dose of a vaccine that was co-created across borders, across governments, corporations, and academia. This ability to co-create in times of great need allow us to deal with the demands of the challenges that we need to deal with. And we're still able to produce certain goods and services, we're still able to ship them across the globe, and we're still able to order online for home delivery. I think you would agree that there is no doubt that we are living in a time not seen since the 13th century. And just in a few decades, we're going to be living perhaps in an even worse time. And I'm talking now about climate change. Climate change could present an even greater economic and health impact. But I'm not here to be desolate, because what we've learned is that, in fact, collaboration is our answer. I've just come from Singapore, and this has left many of us locked in our homes for almost 2 years, afraid to leave our homes, afraid to hug one another, to physically connect and to engage. But despite the risks, I always felt very safe. You see, artificial intelligence had my back, and it was changing our lives for the better. As I left my house for the office, the contract tracing would actually connect me to all of the other phones in my ecosystem, telling me if I had come into contact with anyone that was ill. It would register when I came into the building, register when I left. And at R3I's House of MedTech, with great thanks to our collaboration with UCSF Health Hub and our collaboration recently with the Ministry of Economy and Luxembourg Innovation, we are together now scaling breakthrough innovation for impact. As I arrive at my office, my smart being woohoo device connects me to my doctor to refill a prescription. It monitors my facial recognition to see that I can have entry to my building. It allows me to go contactless in and out of rooms. I can order my lunch online, all while monitoring my temperature, sanitizing my workspace, and a voice assistant will remind me that this meeting is on and even tell me that my heart rate has gone back to normal after this presentation. And this Boston Consulting Dynamics robot, Spot, patrols the park by where we eat. It will tell us if we are too close to one another or if we are gathering in numbers far too great for safety. And so many of us have been called to fly internationally to see a sick parent, terrified that we would not make it in time or we would not be able to get back to our children. Unfortunately, I too have had that experience. As an expat for more than 15 years, I've lost both my father and my grandmother while I was overseas, and this memory will stay with me forever. But these experiences can be solved. This company, Peach and Telehealth out of New York, a company born out of Singapore, now can tell a nurse exactly where this patient is, whether or not it is predestined for decline, and to take interventive action. Every kind of organization, whether small or large, government or private, is finding new ways to operate effectively and to meet the needs of our customers and employees as social distancing and quarantine measures remain in place. Where once a US passport would give you access to more than 150 countries across the planet, now it's as good as a passport from Botswana. We are truly living in a great age of immobility. And as a result, artificial intelligence and our willingness to share data under the reins of good governance, regulatory and GDPR compliance are playing a really important role in enabling this shift to value-based care and providing the tools to support remote communication, enable telemedicine, and protect our food security. But we have a problem in Asia. In fact, 80% of all medtech in Asia is imported. This makes it very complex for any founder to secure funding. We are the second largest healthcare market in the world now, but the annual cost of elderly healthcare is absolutely quadrupling. In fact, it will represent more than 40% of growth in the global healthcare spend over the next decade. But there will be 500 million by 2025 aged over the age of 65. And we lack a huge shortfall of healthcare professionals. Founders need better connections. They need access to capital. They need access to markets. We get a very low valuation in a small market. Europe represents a great land of opportunity for us. Our countries want national security. They want to protect their intellectual property. They want foreign and direct investment opportunities. And they also want to capitalize on export commercialization opportunities. This post-pandemic world gives us an opportunity to recreate together our collective economic and social futures between these two important economic regions of the world. I sit on the board of a runway accelerator in Australia. And I can share with you that for every dollar our startups create, $1.80 is invented in the ecosystem through supply chain and consumption effects. Last year, we created 431 jobs, $38 million in salaries, $145 million in taxable revenues, and $68.3 million in value add. But how do you take the risk for investment as a government, as a corporation? It just so happens that through a longitudinal study over 20 years, an organization called Fingerprint for Success has undubbed the je ne sais quoi that makes an entrepreneur successful, looking at the intrinsic characteristics of a founder who can exit their company with $6 million to $1.2 billion in revenue, versus a founder who can build a company that continues to create and commercialize IPs 10 to 15 years later. This je ne sais quoi is completely quantifiable. I can tell you what are the high motivations that I need in this entrepreneur, irrespective of their gender, their nationality, their race, or their social class. People analytics allows me to understand what motivations I need and to improve that performance. What teams I need to put together in order to drive cognitive diversity and to drive that economic development. And they are very different profiles. Those early stage healthcare entrepreneurs that are going to build to sell in 5 years have very different competencies to those that are going to build long-term lasting businesses. And both are important. In Asia, the first half of this year, almost $4 billion was deployed across 135 digital health deals. But we suffered the challenge of small market syndrome, low valuations, as founders having to give away too much equity in return for too little capital. While in Europe, you raised significantly less on just over half the number of deals, You face a 43-country market under a single European regime. This is enormously valuable for any healthcare entrepreneur coming out of Asia, looking to justify their product for CE mark and to return to deliver against that great need in the region. This makes Luxembourg strategically located for us on the back of a Brexit where UK is no longer as appealing. If I can do my last mile clinical study in the Luxembourg ecosystem, what that means is that I have 50% of the market on my doorstep as soon as I am qualified. What it also means is that I can anchor on a more reasonable margin before I need to rapidly reduce those margins to serve the poorest countries in Southeast Asia. What it also means is I can make a contribution to the fabric of the digital ecosystem that is Europe. We can help to build our smart city know-how into the smart city of Luxembourg, ensuring that our companies can get set up and run efficiently in the region. We work deeply with our insurance partners, ensuring that we move away from treatment to value-based care. We have 3 ultimate endeavors. Of course, to improve patient outcomes and save lives. That's a given. We're in healthcare. But we also want to reduce the number of days hospitalization, rehospitalization, and unnecessary over-hospitalization. And in a friction-free economy, we want to drive transparency into the ecosystem and get rid of unnecessary middlemen that don't add value to improving patient care. Ultimately, we want to improve quality. And I'm proud to say that the FNR is already making value-based decisions in its ecosystem, completely aligned to our mission as private investors in capitalizing these new innovations. One such company that is a perfect collaborator into the Luxembourg Institute of Health ecosystem is Genetics, a company delivering personalized diagnostics, helping providers unlock the power of personalized care through pharmacogenomics. They use genetics and real-world evidence to make sure that they provide data inputs that are more effective for payers and providers, personalizing the pharmacogenomic solutions for patients across critical disease groups. And ViewMind, a company that is making a contribution to the world's largest chronic diseases, has landed in Luxembourg with our friends at Lux Fit for Start. And now we are scaling them across the world, and particularly into Europe and Southeast Asia, on many of the chronic disease types that are important to the ecosystem. Impact is fundamental to the work that we do. We need to identify the business model that is achieving these specific social and environmental outcomes, given our commitment to the principles of responsible investment. We're partnering with companies and hospitals to improve the scale of our impact model aligned with the technologies that are created. We are accelerating the portfolio impact through sleeves up capital, venture building our companies in terms of commercialization, capitalization, and R&D pathways. And we are doing it together with academia, with policy think tanks, and with our friends in venture capital. We are sharing our knowledge learned and our best practices, bringing regional expertise to the European context, and in reverse, taking that know-how back to our own region. And we are looking at it across the entire value chain of the ecosystem, from P-impact analysis, impact management, and impact acceleration. We today need to operate differently. We want to transition away from a supply-driven healthcare system based on activity only towards a needs-based patient-centered system. We believe we need to transition away from a focus on the volume and profitability of services towards a focus on the patient outcomes achieved. And we firmly believe that we need to transition away from fragmentation, in which every local provider is expected to offer a full range of services, to a system in which services for conditions are concentrated in providers with the necessary volume, experience, and locations to deliver high-value care. We must do this. Today, this is the first time we are all having a conversation at the same time, in the same place, at the same level. We must do this for our children's future and also for today. And together at R3I, we believe with our partners, we can accelerate impact. But I'd like to share a new thought, a thought from our friend Jacob. I would like to encourage you to think a different thought.
As a man thinketh, so is he. We've all heard that before. Do we really believe it? Do we really grasp that this world we live in is a byproduct of who we decide we are? As she thinketh in her heart, so is she. There's this notion that we've had stuck in our heads for so long, that the invisible hand of capitalism had to be a selfish hand, a hand without sympathy, that it simply wouldn't work any other way. But what if we were wrong? What if that's not true and never has been? People say a business's purpose is to make money, but it's not. A business's purpose is to fill a need for the market, and they get to thrive as a byproduct of how well they can do that. That's what the invisible hand actually is. That dance of cause and effect, aligning our individual self-interests with the common good. I get to benefit because I have given value to others. Instead of comprehending that, we persisted in the comforting delusion that there was a safe distance in time and space between us and whoever might bear the pain of our choices. And we fed ourselves the false narrative that the market somehow turned our selfishness into more hidden good than the harm we could clearly see it causing. So we simply don't see, because it's so easy not to. But the world is shrinking, and the world is suffering, and we must look. Those distances are no longer safe for any of us. There's no room anymore for fairy tales about the consequences of our actions. We are left at a choice. If we keep telling the story that the market requires the exploitation of the invisible and the poisoning of our earth, then that is what will be. But if we start to tell another story, that their interests are our interests, then that is what will be. What we believe is the crux of it. The market will work just the same. Maybe the dirty secret is it will work even better, free to focus on the needs of all its stakeholders. Maybe the dirty secret is there is a world richer than we can even imagine, sitting just on the other side of our foolish notion that we have to be unkind to each other to prosper. That is the secret, that capitalism, like any ism, is nothing more and nothing less than the magnifier of our intent. It will be whatever it is because of what we are. It does not make us, but only reveals us to ourselves. But if we quit now, if we stand by as innocents suffer and our world wanes, and say, the market can do so many great things, but not this one most urgent thing, then all we have revealed are the limits of our own vision and humanity. The long and short of it is we are the ones who choose. What we believe is all that seals our fate. As we think it in our hearts, so are we. And maybe it's time we think a new thought.
Thank you very much, Leesa. Thank you for your great contributions. Are always inspiring and very thought-provoking. Before taking the break that's coming up, we will now welcome a mix of innovative professionals for a roundtable entitled Emerging Technologies transforming digital healthcare space. And I'm very pleased to welcome, first of all, François Recorbet, Chief Strategy Officer at Bodyo. He has been involved in an e-health startup, seen for 15 years, and he will tell you about his current company. We also have with us digitally Kelly Banning. She is Vice President Sales and Marketing of LiveMetric. She's working on a company with AI, artificial intelligence and machine learning, mobile health apps. And we have as an expert Christian Oberlé, the President of the National Sick Fund, the Caisse nationale de la Santé. And our moderator for today will be Jochen Klucken, who is a FNR Pearl professor and a professor of digital medicine, who will be moderating this round for us. Please all come to the stage, and then we will kick off the round. Thank you, Jochen.
Can you hear me? Oh yeah, you can hear me? Wow, I can't see you. Welcome. I really can't see you. Amazing. So glad to moderate this session here. My name is Jochen Klucken. As Carole said, I'm the newly recruited FNR Pearl Chair for Digital Medicine here at the university, also with a close collaboration and affiliation at the Luxembourg Institute of Health, and also with the Centre Hospitalier du Luxembourg. So I'm a doctor thinking digital, and I try to understand, also with the research what I'm doing, how technologies can be integrated into healthcare processes. So we just heard the market is huge. There's experience in company building and business creation and entrepreneurship. But I always claim there's not so much experience with all these kind of new technologies from the medical point of view, and I try to help there. In my academic career as a researcher, I also developed technologies myself, and I even co-founded some startups. So I'm bringing also this expertise in. And I think what we heard just before, the market is becoming huge. It's a great area of development here, but I think there are some complications as well. And I always say these complications usually do not come from the patients because they're globally pretty much the same. And the problems in terms of the disease are similar. In terms of their environment, of course not. So I'm wondering why aren't we successful with good tools quicker? And I'm very happy to have a conversation today, and I think one person is joining me in this round. I don't know, maybe we sit on this side. Christian Oberlé, the President and Director of the Healthcare Insurance here in Luxembourg. Welcome, Christian. And so I'm very happy to see you here because I'm like the researcher thinking about what evidence do we have to bring to convince doctors, patients, and societies, and maybe healthcare payer, that they basically pay for these new tools, which is definitely part of the market access. And you are also the person that has to think about, does it really make sense? Can we spend the money? So welcome on stage. Maybe you can introduce yourself in a few words, and then we come to the companies that should tell us a little bit what they're doing.
Hello, I'm pleased to be here this afternoon. So, like Jochen said, I'm Christian Oberlé, and since 2 years now I'm president of the health insurance company here in Luxembourg. Before I was for about 18 years director of a hospital group, so it helps me to understand also as different stakeholders who have to handle all these innovations in health. And before I was working in the consulting area with one of the big four. I think from the point of view of a health insurance company, first what we always ask for is evidence. And if there is evidence, we finance. And there we have, I think we see innovation and the acceleration today. We have to find new ways for thinking about financing, and that's for me one of the big challenges now when discussing with young entrepreneurship or with innovative companies who have often a good project, but who have not the time to make this the long classic way of evidence proving. So we are open today because we see the sense of all this. We are open enter in that cultural change, but it will be a long way to do.
Yeah, thank you very much. I think it's very important to have us here, evidence reimbursement, because I think in the end, after you challenge the GDPR and the MDR, FDA, etc., technical approvals, market access means that somebody needs to pay for you. And maybe that is a question that we will ask the presenters of nice, cool, new digital health applications. And these are basically representatives from two companies. I think one is a French company and the other one an American and US-based company with a lot of international experience. So I'm very happy to have François here, Recorbet. I think we start with you because I'm not sure if the uplink to Kelly Benning is still working. So welcome on stage. Maybe you can tell us a little bit about what your product is, what your company is, and what your experience is in entering this kind of new market.
Sure. Thank you, Jochen. We'll probably have a little video running in the background when I talk. I had a presentation for you, but it didn't work with Keynote. So I'm François Recorbet. I'm the CSO.
Imagine
if you can turn off the sound, please.
No matter where you live or who you are.
Yeah.
A world where technology
so I'm the
serves
CSO
your
of Bodyo,
health,
joined
and
the
where
company
prevention of serious illnesses
less than a year ago
like
after
heart
15
disease
years of experience in the e-health sector, both in nutrition and IoT. And so Bodyo, what we do is basically a telehealth, 360-degree telehealth solution that provides a health checkup in 6 minutes on 26 parameters, using self-screening health stations that are smart and connected. You see two devices. You'll see them running on the video. Basically, what we want to tackle is the issue about access to healthcare. We have an issue about accessing the market of healthcare, but a lot of patients, a lot of people have that issue about accessing healthcare services, whether they live in medical deserts or not. We also tackle the issue of health in the corporate world, the health of employees, fighting chronic diseases that are very recurring, especially in North America, but also in Europe. And we're also dealing with the autonomy of elderlies, like trying to keep the autonomy the longer as possible and helping them to maintain a good living condition, even in retirement homes. So what we've come up with two devices. One is a closed-in cabin that you've seen, which is very well adapted to places where there's a flow of people, like in public places, whether it's a hospital, an airport, or even a commercial center where people can just stop by and get their measurements done. And this is really including the process in what we call a prevention and health journey. So prevention is one of the key issues for us, because if you can prevent the occurrence of conditions, it saves a lot of money to the health care system, of course. We could say that with Mr. Oberlé. And then to the next step, we also have a curative path. So it's more like getting in touch with, if the condition requires it, we can get in touch with a doctor through a teleconsultation service. And do a diagnostic with specific connected sensors that are in both cabins, the one closed in, and the health lounge, which is another cabin that is really well suited for spaces that we will privatize and where people who need assistance can also be taken care of. And so basically these are our two devices, a lot of technology behind it. We are not a teleconsultation company. We are a technology company, and we're an enabler of the e-health and trying to give the access to healthcare to the most people in Europe, but not only. We're a worldwide company that started in Dubai in 2016 and has been a French company since 2018.
Okay, thank you very much. I think we will ask questions to enrich the discussion later. And I see Kelly is on board now. I think we had problems in connecting you. So welcome. I think this is a long distance call. You're in the States right now?
I am.
Okay, what time is it?
Or good afternoon to you all. I'm Kelly Benning, and I'm calling in from Colorado.
from Colorado. Thanks a lot. Great to have you here. And as I said, I don't know if you have listened to the first words, but I think we are very curious to see what you have developed as a new device that should help patients and doctors and the healthcare system. And in particular, your experience from the American healthcare ecosystem and maybe also the reimbursement world, how you manage this in the States, and maybe even some ideas for a later discussion, how you think about the European healthcare system or the systems, and that could be something for later. But maybe you give us a short presentation of who you are and in particular what your product and your company is doing.
Yeah, thank you. I appreciate that. If you don't mind, I can share a couple of slides that will help give a better overview of LiveMetric. Sorry, let's see. May just be easiest to do it this way though. Okay, so thank you for having me today. I'm excited to be here, and our company is headquartered in Luxembourg, so excited to be part of the ecosystem that is happening in Europe as well as what's happening in the US. LiveMetric was developed in 2016, and at our basis, we are a wrist-worn blood pressure monitor that is continuous and passive with accuracy equivalent to the arterial line in the ICU. So the results that you can achieve in the ICU can now be achieved at home, and they can also be continuous so that patients and users can have results in real time. This is really important because hypertension is at an all-time high. Approximately 1 in 3 deaths are due to hypertension because it leads to things like stroke and heart attack and kidney disease. And 1.1 billion people worldwide have hypertension, and 75% of them are uncontrolled. The reason for this a lot of the time is that hypertension, as you know, is known as the silent killer. It doesn't have a lot of symptoms associated with it, and so people tend to not pay attention to the disease. They don't put on their cuff. They're not taking measurements like they should. So LiveMetric really is here to change that by offering some passive ways to monitor your blood pressure, send that results to your provider or family or friends, and really help you better understand your disease state in real time. There's some other areas as well that LiveMetric is reinventing, and that is the ability to diagnose or predict the risk of cardiovascular disease much sooner than you would, say, if you were to go to the cardiology office or to have an ECG or an echocardiogram. Because we measure actual pressure, we actually pick up the full pressure waveform. And through that full pressure waveform, we're able to look at things like aortic regurgitation or valvular impairment and help alert users and providers to the risk of patients who may or may not have these conditions. We're super excited about the full pressure waveform. We can even see within 1 heartbeat if somebody has taken their beta blocker or medications and what that's actually doing to their blood pressure. So we're currently in quite a few studies right now looking at specific to cardiovascular disease and congestive heart failure, what we can look at and see what we can diagnose early on with our passive wristband. This is another really great example of what measuring actual pressure gives you versus using a cuff or another device. Because you get that full pressure waveform, we're also able to diagnose and see risk of masked asleep hypertension and morning surge. These things are really important because they're monitoring your blood pressure overnight, which has never been possible before. If you wear a cuff at night, it wakes you up, or these types of things. So for the first time, we're going to have nocturnal data where the patient's actually asleep, and we're going to be able to see how that nocturnal hypertension is impacting their overall care. As you all know, in the marketplace, there are quite a few things driving changes. And as was mentioned before, reimbursement is one of those areas, which we can talk about in just a second. But really, because of COVID, as care has moved into the home, we're seeing less and less patients who are actually showing up to have their blood pressure monitored, to be monitored for cardiovascular disease and their risk of disease state or a risk of event. So we're also seeing that with the silver wave or the aging population, as well as the healthcare costs that are growing. These are all kind of the macro things that are really pushing for remote patient monitoring at home, and the ability even to have a hospital at home type scenario where you're monitoring somebody the same as you would in the ICU. Some of the micro forces that are driving this change, the efficacy of treatment. So being able to monitor somebody in real time means that you have better access to knowing what their treatment should look like, and being able to deliver that care in a lower cost setting, their home or another facility where that cost is much lower. As well as engaging patients in their own care, because providers can't take on all of the care that is needed across the world for every patient. So patients have to start to engage and are engaging and want to engage in their care. And then lastly, the availability of data is really important, both to the user and to the provider in the right kinds of care. So let's show this last slide, because there's really important things that are driving the use of remote patient monitoring and hypertension in the US. And I think we're going to see these things following suit quickly in Europe. There's new codes, new reimbursement codes that are called self-monitor blood pressure codes, or SMBP codes. And in January, the American Medical Association, American Heart Association came out and said, we really want you to monitor blood pressure at home. So we're now going to reimburse the provider for that, so long as they're checking that patient's data once a month. In the US, it's going to be about $200 per patient per year just to monitor their blood pressure. Those are brand new codes. We're seeing them being activated in large healthcare systems across the US. And then there's also remote patient monitoring codes. Those have been active for quite a while now. And then chronic care management codes. In addition to that, we're seeing a large swing with Medicare Advantage or insurer plans who are sending at-home monitoring devices to their members in the hopes of avoiding a hospital trip or a readmission. So we're having quite a wave right now between the reimbursement and what's going on with employers and payer plans in home blood pressure monitoring. So I think I had about 5 minutes. I apologize if I went over. I'll leave it there, and I'm happy to answer any questions.
Yeah, thank you very much. Very fascinating technologies. I mean, to both of you, I really like these concepts, because assessing physiological function in a pathological situation like disease, I think is the first step of doing a diagnosis in medicine. And both of you showed an approach that measures, I mean, you have a more multi-parametric assessment. You particularly look at the blood pressure. One question for me arises as a doctor. How would you self maybe explain? You said you do this in the home monitoring, and I understand that this is relevant. You do it in a very, let's say, defined situation where the patient is in the box, and you record also probably blood pressure and other cardio function. I mean, in the end, a patient who is doing this, either in the box or at home, should feel, yeah, I'm better now since I'm using this. So my question is a little bit to you. Do you have evidence or an idea how this evidence can be generated, that a patient says, now my hypertension or any other disease that you look at is really better? This would be, I don't know, who would like to start? Maybe ladies first. Kelly, do you have some evidence that patients say, yeah, it's really better now?
No, thank you. I appreciate that. It's a great question, and something that digital health companies have to make sure that we answer that question. Not only is our program and our platform valid clinically, but is it valid in the real world? Will patients wear it? Do they like it? Do they engage with it? And so as we come out of all of our clinical trials that we use to achieve our CE mark, and we're using to achieve FDA clearance, now we're moving into this real world data where we're putting the band on actual users and determining from there what the impact is on their level of engagement and their level of feeling like they have better data from which to manage their disease. So for example, if somebody puts the band on and they realize at 4 p.m. that their blood pressure is high, they can look back and think, I might have had a high salt lunch, or my behavior and lifestyle this week, I haven't been exercising. Those kinds of things that might not be available to them had they been wearing a cuff, because they have to go home, put their cuff on, sit down and do it, which most people aren't willing to do. So we are recognizing and seeing in early stages, real world trials, that patients are really liking the passive nature of the device. And in particular, having that nocturnal data has been very important for diagnosing risk. And so patients are coming back to us and letting us know how much they like and enjoy wearing it at night. It's had a significant impact in their life versus having to stop and sit and put on a cuff and take those manual measurements and then send them to their doctor.
Okay, François?
Well, Bodyo is a very young company. We launched our 2 products last June at Vivatech, where we were invited to introduce these devices. Although the devices have been launched in Dubai a few years back with the Dubai Health Authority there, we don't have today as much evidence. One evidence we have is, since we've been showing it in the shows, it's very attractive. A lot of people come and want to get measured, so that's a kind of a good sign. But we are actually starting a pilot next month with the CHU, the hospital in Nice, along with the city, and for monitoring students at the university. We have other projects with really to measure the acceptability, not only from patients but also from health professionals. With the hospital in Nice, with remote areas like the hospital in Tende, who has been out of reach since a major flood happened and shut down the roads between Tende and Nice, for example, where doctors can actually also have an expertise from a specialist doctor in this central hospital using our devices and the connected sensors. And another project we're working on, a pilot that should start before the end of this year in Montreal in Canada, where they have a typical project studying a population of elderlies in a particular neighborhood, where they will actually install a device in a privatized room with a nurse, and they will have all the old people who come and walk there every morning to get their coffee, to measure them and to inscribe this into, an evidence-based monitoring program, along with a more global smart city program. And from there, and that's done with the CHUM, which is the Central Hospital in Montreal as well. So yeah, we have a lot of things happening to measure this evidence. We are getting closer we have a meeting with the hospital Schumann later on this afternoon. So yes, evidence is key. And for us, from the start, go from what we do, because you see it's closed-in cabin for one. The user experience is really central. So we're not doctors making technology for doctors. We're non-doctors making technology for patients, for people like us. And to make this attractive technology, well, really incite people to go and get checked. And once they're there, they have a mobile application that there too, where the UI is like the user interface is very pleasant, easy, clear. So it incites them to get monitored.
And just my last question, maybe then I hand over. This is a type of research to generate this evidence, but it's not a basic research showing, for example, that the blood pressure curve is actually correct or not, which probably is funded by public money, because it's a basic research. That's at least what I experienced. But it's really this industry-closed research. Do you find it easy to find money that funds these clinical trials for evidence of your product? Maybe experience from the States and from Europe. I don't know if or from
Kelly can go.
Yeah. Another great question in terms of how are we funded and how do we keep moving forward? When we did our clinical work, we did that on the state side at the University of Chicago, Columbia, NYU, and the University of Chicago. And that was funded by our CEOs and co-founders, as well as some individual private investors. And when we look at that validation data, it was done in the ICU. So those were sick patients laying in a bed to prove our correlation to the arterial line. Now that we're in real world clinical trial, we're outside of the ICU, patients are wearing the monitor at home. etc. And we're coming across organizations, large healthcare organizations, 120 hospitals plus, who want to utilize LiveMetric to prove that they can have faster time to control for their patients with hypertension, or they can have faster time to titration of medications, better control over nighttime hypertension. So we're seeing large healthcare organizations like that willing to come in and help co-sponsor, working together in phase 1 commercial agreements to prove out that the process and the platform work well for their population, and then move forward with larger contracts. So we're seeing both. We definitely receive funding from investor side, and then a lot of our funding is also coming from interested healthcare organizations. And the same is true in Europe. We're starting commercialization in Spain with long-term care facilities who want to distribute it across Spain, and we'll be distributing through retailers such as Boots in Europe.
Do you get public money, or organizational money from hospitals is probably again not public?
In our case, it's a little bit different because we don't manufacture sensors, so we don't have to go through clinical trials to show that they're working. We integrate already certified sensors into a platform that collects all sorts of data. So our actually trials are more about evidence, like showing that yes, it works and that it brings good results and will save money to the healthcare system. So the way it works for us, it's usually through pilots that are financed either by it's usually public money, to be honest. Whether it's a local, like for example, the pilot in Nice is financed by the city of Nice. The pilot in Montreal is financed by the Quebec Agency for MedTech Technology Transfer. And the other contacts we have for clients, they're all often ministries of health, like it's the case in Saudi Arabia, it's the case in Thailand, where they would buy a certain number of machines and to have a live trial of the machines and see what happens, and then they can spread it nationally. So it depends on their investment capabilities as well, because Saudi is probably more, in a way, more
and Christian, Luxembourg, I heard, has a public-private support concept. What do you think from the healthcare insurance?
I think from the point of view of a health insurance, we do not pay research or we do not pay developments, we pay treatments. And I think as a health insurance, we have a big responsibility, because if you offer treatment to a patient, if there's a commercial company that offers a treatment to the patients, the trust comes or from the physician, or if ever we would give our authorization for reimbursement, patients will trust us. They will think that we have done the necessary to be sure that the product is okay. And I think that's why this in this area now of e-health, this whole process that has to be rethought, we have to accompany, to be within this process, to be sure that the final process that will help the companies to bring their product near to the patient, this whole process is okay. We should not control when the process is finished. We should, from the start on, being integrated in that process, because that helps ourselves to make that cultural change. Another cultural change we have to do is we are not prepared for preventive medicine. There's only a small part of our financing that goes to prevention care. I think a lot of a big part of the digital way of the e-health solutions bring very new advances in preventive medicine. So we have also, as a health insurance company, we have to go this way from start on to understand ourselves that this brings something to the patient. So for us, it will not be only like historically the physician with its prescription that will be the starting point for reimbursement, but that could also be some evidence by new authorities. We have to create those authorities in Luxembourg. They do not exist. And I think something that has been underlined now and that is very important is also that the health professionals, they believe in the system, but health professionals, they see so many things, so many different treatments, so many innovations every day. So I think that's one of the most difficult parts will also be to have that people on board. We see it with very basic products like the patient file. It should be self-telling the advantages of patient file, but it's a very hard work to convince professionals that this is something of useful. It will be even more complicated with solutions like we saw today. I think there we have altogether a job to do.
Yeah, I think the patient file is that shares the data, and the doctor and the patient doesn't have trust because he doesn't get something out of it. And then you have these nice technologies, which you probably get something out of it, but they're somehow not connected to the patient file. What is I'm just wondering, you have experience, you said, in different countries and also in the States. What is the biggest hurdle, you would say, in terms of, the certification, technical certification, etc.? Yes, it's a to-do, it's a must, but it's doable. It's clear definition. In Europe, we have a unique European regulation, MDR, FDA is very similar. But how, everything, prevention is good. We can do this. It's very, as a doctor, I can see that your technologies help in prevention and disease monitoring. So why don't we do it? We just heard the market is big. Is there anything that blocks you? Do you have an idea? What's your wish? If you have a wish list here, what would you put in? What's your biggest wish? In particular, I don't know if we see Christian Oberlé as a representative of a healthcare insurance or reimbursement or something else. Is there anything where you say we need this?
The wish is a bit difficult to say because the difficulty of the healthcare sector is like it's so diverse. You go from one country in Europe to another and you have a different system. You even go to one, even in France, you go to one region to another, it can be different. So we have to struggle with all these different ways of dealing with healthcare, whether it's reimbursement or not. Definitely reimbursement for prevention will be a great help because the day, telemedicine, you have three aspects of it, the telemonitoring, the teleconsultation, and the tele-expertise. Those two are covered, at least in France, they are reimbursed. It's not the case everywhere in Europe or in the world. But the telemonitoring, it's reimbursed nowhere. Like there's the DIGA now in Germany that is helping, of course, but it's really the poor parent of the telemedicine. So yes, it would definitely help, but if we could also uniform, have a more heterogeneous sector, it will be easier. So that's why the US, in a way, it's a bit easier because you have one large market, one large country, and it's fairly the same everywhere. So the actors are national. So it's not as hard as Europe.
Is this true, Kelly? It's easier in the States? You showed the procedures that can be reimbursed, but can you sell the thing now to all American people?
We can, and we plan to do so through retail channels and then as well as through hospitals, healthcare systems, and payers. But I would say for us, it's actually been less of a hurdle in Europe than it has been in the US. And we started commercialization in Europe earlier than we have in the US because of the ease of some of those things. And as part of my wish list, it would be the ability to change behavior, both from the provider, payer, and patient side of things, to accelerate the use of self-monitoring to better predict your own outcomes and to better manage your own chronic conditions. So, right, we saw the car industry do this. Electric vehicles, came out many, many years ago, and companies began to use them to save resources. But now we're seeing it where there's a shift in the mindset that people want to impact the planet themselves, and they want to have a piece of that, and they want to be responsible and socially part of that. But it took a long time, and it's still going to take another 10 or 20 years before we even get to full marketplace for e-cars. So my wish list would be to accelerate the behavior and patterns behind self-monitoring patients, providers, payers taking more responsibility in that three-pronged relationship, I think would be key to acceleration.
So variety of the healthcare system and reimbursement concepts, but also an acceptance for digital tools is needed, which basically is the trust that you mentioned in the end, because acceptance is generally generated not by understanding, that's the first key, and evidence, the second, but then in the end by using a trust. So we are in the beginning of this. Is there anything from your side, maybe Christian, that you would wish that these two companies do, that you would say, now you can get my money?
I think the company's job is to do use cases. Use cases bring trust. I think our job is to put in place the governance, in the point of view of Luxembourg, to put in place the governance that helps the companies to develop their projects. And I think also we have our responsibility in Luxembourg to make the access of the European market faster, as every European country has this responsibility.
Yeah, I think that's a good statement. The CE mark doesn't make your product, right? Any question? I'm sorry, I can't see you. I don't know if you can turn off. Is there any question in the audience also, or some comment on the topics that have been mentioned? Not so far. Okay.
Yes.
Oh, there's. Sorry.
Yeah, sorry, we have a question live. So I have one question for Bodyo. Where are you deploying your telemedicine cabin? Do you target a market in particular or a country?
We unfortunately we didn't have our slides on, but we have three main markets, I would say, in terms of deployment. The first one, as I mentioned, is healthcare access and medical deserts. So it's working with hospitals, medical centers, but also retailers, pharmacies, wherever people live and where they can they don't have access to healthcare services, and where we can bring the healthcare closer to them. The second one is really the corporate world. Like, there's a big issue about health safety, like safety issues at work. The US is very well advanced in corporate wellness. So we work a lot in this because chronic diseases are a big factor of cost for companies in terms of absenteeism and the reduction of productivity. And the last market that we're targeting is really the well-aging. So helping people to be as autonomous as possible and also to maintain a good health condition even when they're in the retiring home. In terms of geography, we were born in Dubai in 2016. The founder, Patrice Couta, has been living there for 20 years, has made prevention one of his main goal, and he decided to bring everything back to France in 2018 because of the resources that we couldn't find there and all the dynamic we could have in Europe for this kind of product. So we are, before being French or even European, we're just international. So we have a reach now, of course, in the Middle East. We've just opened Canada, and we'll deliver the first machines in a couple months through these pilots that have been sighting. We're targeting, of course, Europe, and Luxembourg has been one of our priority in the past 8 months now, like we've been discussing with Lux Innovation, for example. That's been very helpful. And we have some good traction in Asia as well. So basically, the issues we are dealing with, we find them everywhere in the world. So then our distribution, our channel is going through distributors to help us to understand faster the local markets. So yes, so we don't have a priority, but we're a global company.
Okay.
Yeah, and we also have a question for LiveMetric. So do you plan to expand your company in Europe? And if so, are you GDPR compliant?
I believe you asked if we're going to expand in Europe and if we're GDPR. Is that correct?
Yes.
Okay, thank you. We are planning to expand in Europe. So right now we have business in Spain and France and Germany. We will be distributed at Boots across Europe as well. So we are working with Hungary as well currently, as well as a couple other countries on commercial contracts. So we're wide open in the European market and ready to work with distributorships or hospitals and healthcare systems across Europe. We are GDPR and we are HIPAA compliant in the US.
Thank you.
So come to Europe, come to Luxembourg, we will explain how Europe works and then it's easy. Okay.
I wanted to, yeah.
Okay, I think time-wise, we're pretty much at the end of this discussion. I think there's a lot of open questions still, and maybe some of you can be approached later. I like this concept prevention a lot. We can prevent disease and we can prevent costs, and the patients are pretty much the same. So let's do it. And with that, I like to thank the speakers and the participants, and of course you for your attention, and I wish you a wonderful rest of the day.
Thank you. If I can add something, you can see the iPod, like our cabin, at the startup area. So if you want to try it, you're welcome.
Thank you.
Thank you.
Hello, we are back live for the second part of today's afternoon dedicated to digital health, and I'd like to introduce you to a dear contact and colleague, which is Sarah Bouchon, which is Director of Market Intelligence of Lux Innovation. She and her team have prepared an exciting talk to bring together for us the trends of digitalization of the healthcare sector for Luxembourg. Sarah, if you can hear us.
Good afternoon,
Over
Carole.
to you. Wonderful. Thank you.
Thank you very much, Carole, for this introduction. Good afternoon to you all, and thanks again to the ICT organizers for that kind of invitation. I would have loved to be here physically with you. Unfortunately, my husband has COVID, and I have to quarantine at home. And in the end, I'm thinking that if I have to talk about digitalization and healthcare, it's a kind of a perfect setup. So in the next 15 minutes, I would like to share with you the main insights we gained from an analysis we did on the main market trends related to the digitalization of the health sector. So we decided, or we wanted to investigate these issues for two main reasons. On one side, so at Lux Innovation being the innovation agency, we need to be forward thinking. We need to have a good understanding of the main drivers, main market drivers, which will impact our sectors. The health sectors is one of the priority sectors, which has been identified as a key ecosystem for the diversification of our national economy. And as it was mentioned by our minister at the beginning of the afternoon, we are all aware that digitalization will heavily transform the health sectors in the next years. So we wanted to have a better understanding of the main opportunities, but also of the main challenges raised by the digitalization in the health sectors. And we also wanted to highlight the market opportunities both for companies active in the health sector, but also for the non-traditional players, such as the digital companies. So we are lucky enough at Lux Innovation to work every day with innovative companies which come to us and discuss their innovation projects. And this has led us also to understand how these market trends translate in our national ecosystem in terms of innovation. So I would like to share some examples. I cannot share all of them today, but that's a good way to see how national ecosystem is keeping pace with the market development. So we have identified 5 main areas where we can expect huge market opportunities. We will analyze them one by one. So the first area where we expect a big transformation, it was said already several times by the previous speakers, is that the focus will be put very strongly on preventing disease and maintaining the health and the wellness of people. And of course, here digitalization and data collection will offer very huge market opportunities, especially they will translate in what has been called by some researchers as quantified self. So the multiplication of devices which collect data on our different health parameters just allow people to have a better understanding of their own health status. This data collection is also a very good support to define new data-driven incentives. So to make sure that people will stay in good shape, they can also rely on the different types of data collected. That's also very important that we understand better in the future the main social and environmental determinants of health. And there are also here huge market opportunities related to the way we eat, the place where we live, or the environment where we work can have an impact on our health. And once this impact is better understood, there are also some ways to maybe positively leverage these determinants to increase our health status. So in the end, we are really evolving towards what we call the P4 medicine. So a medicine focusing on prediction, prevention, but also personalization and participatory medicine. And to illustrate with this main trends, I would like to share with you 3 examples, which are 3 companies which are customers of Lux Innovation. And the first company is SportsMed. SportsMed has released their MobiCare platform. That's a tool which allows assessing the fitness level of people over 60 years old. And that's a way to help them to stay healthy and mobile. And SportsMed was or has developed its tool also with the support of Lux Innovation and in the context of an R&D project co-funded by the Ministry of Economy. Another nice company we've supported in the context of our Fit for Start program is No Big Deal. You can check your app store and look for No Big Deal. They propose an app which allows people to make exercise, so they count how much you do exercise, and this allows you to get free or discounted products in your preferred shops. So that's also a great way to use data and combine marketing and health impact. And the last company, which was also one of our laureates in our Fit for Start program, is NEOM, which provides a platform for personalized dietary recommendations based on each individual's metabolism. They provide indications on what is best to eat or not to eat based on your own characteristics. So that's a quick overview, and it shows how emerging and new business models can emerge from this focus on prevention and well-being. The second trend we observe is really putting the customer at the center of the healthcare delivery. And we look here at the market opportunities which are linked to the way care is delivered or will be delivered in the future. So under this broad area, we of course see the market opportunities related to the setup of an omni-channel care delivery, which means that both in person but also virtual e-health solutions will be developed. That's basically, and I really like this expression, that's building the hospitals or the healthcare system without walls, meaning that there is really a combination of both physical and virtual places for care. That's an essential element to make care more accessible, but challenges are also related to digital literacy of the customers, and in particular of the older customers. This omni-channel delivery must also be supported by the digitalization of all the processes which are beyond the care system. I mean here all these booking appointment facilities, but also the payment, reimbursement, or visualization of results are offering huge market opportunities linked to digitalization of these processes. For people who live in Luxembourg, I'm sure that you are all aware of Doctena providing this appointment tool and connecting patients with different doctors in the country. And Doctena is one of our historical cluster member, our health tech cluster member. But there are also market opportunities related to online prescription tools, for instance, or digital reimbursement processes. In this context, it's also very important that we ensure consistency of the data related to the customers. So at some point, it's very important that all data related to the healthcare journey of one person are accessible on the platform. And that's why we really expect data platforms to be key elements of this of the future healthcare systems. As our minister mentioned, the Minister of Economy is now working on a national data exchange platform, which aim at centralizing but also making data interoperable and standardized in a secure environment to allow different practitioners to access this data. And we also have a very good presentation by our colleague Ralf on Gaia-X, which at European level also aims at addressing the interoperability, standardization, and security issues related to the centralization of data in healthcare. But we also have here non-traditional players position themselves on this market. And I would like to mention here Regify, which is a Luxembourgish company proposing cybersecurity solution with specific solutions for health data. So that's also a way to see that there are new entrants on this healthcare market. And one of the last elements of this trend is related to improving the customer experience in hospitals. And here, a company such as Virtual Rangers, which has worked on a virtual reality helmet for kids, is also a very nice example of how technology can transform the health journey of the customer. The third trend we have identified is then related to the more and more personalized nature of the cure. So once people are sick, we expect in the future that market opportunities will be linked to really personalizing the diagnostic, the treatment, and the way treatment are administered. We've said and we've heard before that, for instance, artificial intelligence will dramatically improve the way diagnostics are performed, making them more accurate and quicker. And on this topic, and they have been also quickly mentioned in the speech from Leesa. ViewMind is a company which work on this issue, so using AI to perform more accurate diagnostics. But I would like also to mention here the importance of increasing the computing power companies may have at their disposal to implement these types of technologies. And the inauguration of Meluxina, so the high-performance computer last June in Luxembourg, is also something which probably will accelerate the market adoption of these technologies here in Luxembourg. Regarding personalized medicine, we are aware that that's also one of the strengths of our ecosystem in Luxembourg, and mainly thanks to the public stakeholders working on these issues. But there are also very nice startups addressing these aspects, and I'd like to mention here what LuxAI, one of our Fit for Start company, is proposing, and maybe you know them. So they have this little QT robot which assists children with special needs in their learning activities. But we also have Exoathlete, for instance, which develops wearable exoskeletons for the rehabilitation of people having suffered neurological or muscular injury. And Exoathlete was first identified at the Skolkovo Foundation, with which we have collaboration agreements, and they managed to open also the activities here in Luxembourg. To deliver this treatment, we can also see that the world of medical devices are evolving towards more connected medical devices. This is exactly what Cypharm is doing. They have set up high precision infusion pumps which is also connected to a platform which helps understanding when is the right moment based on the patient's data to administrate the treatment. So that's also a very good national example of the way this market opportunity is addressed. The fourth trend we've identified is related to the ecosystem, which is at the basis of the healthcare as we described it. So with here a focus on the two key stakeholders, so the hospitals, but also the pharma companies. And one key element is also the importance of building resilient supply chains in the health sectors. Regarding hospitals, it's striking to see that progresses in automation, robotization, or in AI will be key in the future to address staff issues, which are now very important in hospitals, and it will also help these structures to improve their performance, for instance, to realize or automate some tasks such as triage and admission of patients and so on. The digitalization of the pharma industry is also very important. We know that the pharma industry is not a strength of our ecosystem. However, we do have some companies not coming from this sector, but providing relevant solutions. And I would like to speak here about ITTM, which is a more digital and software company which provides and data integration and knowledge management solutions, which focuses also on the data related to clinical trials and making them standardized and harmonized. And as the last point here, the building resilient and also regional supply chains is really a direct outcome of the COVID-19 crisis. We've seen, for instance, in Luxembourg that in a very short amount of time, we managed to have already existing companies, but also new companies positioned on providing masks or antiseptic gel, either by repurposing some of their production lines or by building new production lines here in Luxembourg to ensure that this type of strategic goods are delivered at local level. And some of them were supported by our Fit for Resilience program, which was set up by the Ministry of Economy and Lux Innovation during the crisis to help companies recover from the crisis. And as a last trend, and I'll conclude my presentation with this one. It's also very important to create a collaborative, compliant, and innovative environment for the healthcare sector or ecosystem of the future. Collaboration was very important during the crisis, and it should stay so after the crisis. That's reflected already among the collaboration the different ministries and stakeholders have in Luxembourg. That's also now materialized via the Gesundheitstisch, which brings around the table all the relevant parties to work together on a national healthcare plan. But I also would like to mention here the call for public-private partnerships set up by the Ministry of Economy, the FNR, Lux Innovation in the health tech sector, and to bring public and private partners to work together on innovation projects in the health tech sector. We also see that it will be very important to leverage all the data which are now collected to innovate or to provide healthcare innovation in the future. And here we've heard already a very nice presentation on the Cleanova project, which aims exactly at exploiting and leveraging this data for healthcare innovation. That's very important that we also think about the regulation and compliance issues in this context. Digital aspects of the healthcare products are for the moment not addressed in the regulation, and we know that at European level there is a reflection on this, and that's something with which we also need to keep up at national level. Just to conclude, you'll see that on our website at Lux Innovation in the coming days, you can see the report we have used as a basis for this presentation. We've seen very nice new companies emerging or new business units being created here in the ecosystems. We are also very much aware of the coming challenges that expect our companies, and that's also why Lux Innovation is here to support every company here in Luxembourg in its innovation project. Thank you very much.
Thank you, Sarah, for your insights, as always, highly interesting. Now, on to the next speaker. I would like to introduce you to Kyriakos Hatsaras. He is the European Partner Chief Manager of BioMind, based here in Luxembourg, and his expertise is technology adoption by healthcare companies of new AI softwares. It is a big task, and you're here to tell us about about your best practices and how to go about it, and maybe some recommendations for other companies. So, Kyriakos, over to you.
Thank you, Carole. Can you hear me well? Good afternoon, everyone. We are late in the day, so I will just try and make the presentation as exciting as possible for everyone in the room. We are here to, in effect, honor the motto of the conference, to share our experiences for that key moment, in essence, when we have addressed our regulatory and now we need to generate evidence. So we need to start the journey of our product or technology of adoption in the healthcare market. So how do we go about doing that? So just a few words about BioMind and indeed the talk and about me. So as Carole said, I'm the European Partnerships Manager. I design and oversee the implementation of the partnership program in the UK and in Europe, or in the European Union now, the UK being a separate legal and regulatory jurisdiction. So what I'm going to talk about is some of the best practices we have seen and applied, and I will also briefly discuss how they apply in our case for our product and our technology. So we can start or if I'm to do this, we need to move one slide further. Yes, so thank you. So BioMind is an artificial intelligence clinical application suite. It has been certified as a software as a medical device for classification of brain tumors, classification of stroke pathologies, and COVID-19 pneumonia. Its intended purpose is to provide that assistive diagnosis for radiologists and other medically trained professionals. It is designed in Singapore, developed in China, and introduced to the EU and UK markets in 2019 to 2020. As a company, we're indeed very young. Thank you. So the company was founded in Singapore with its research center in China in 2018 to 2019. And in Luxembourg, we have been since mid-2019. You can see just the two key screenshots here as to why the system is or how it can be made useful. So on the left-hand side, we see a classification of a smaller tumor, a glioblastoma, already quite small, at least at this, on this image. And being it quite small, it might pose difficulties to less experienced neuroradiologists and radiologists in its classification. Normally, this review of the scan would take about 20 minutes, even in a specialist center. The system does this in about 5 to 8 seconds. So you can imagine that in a high workload situation of a number of scans to be reviewed, that reporting, review, and turnaround time is substantially reduced. So this is just an indication of the health economic benefit that the system readily brings. On the right-hand side, we have a very, very small embolic infarct. Now that is possibly the onset of a stroke, and it's very small, and the patient might present with an initial symptomatology in terms of a headache and loss of motion in the right part of the face, if that's the, if I'm looking at the scan well. So the system can indeed identify the pathology and offer that assistive diagnosis. So in essence, it is particularly useful for hospitals where that advanced expertise in neuroradiology seems to be lacking. So, in essence, when we talk about healthcare technology adoption, we talk about how we make a difference to the lives of patients and the everyday reality and workflow of healthcare professionals. So, the first criterion really is for us to have a high impact intervention. What does high impact intervention mean? So, it has to meet an unmet medical need. It has to have that health economic benefits trajectory of reducing costs, or to the very least be cost neutral. And also it has to make an impact on policy. And if your technology can do all three, if it can meet all three of these criteria, then it is likely that the impact would be quite substantial. And in our case, we know that, and it's been evidenced in the literature, that brain tumor care is rather stagnant and with no progress at all since the 2010. So there is a high unmet medical need for what is the 10th most significant brain tumor or type of cancer in terms of prevalence around the world. Stroke remains an important cause for death across the world, currently second. And of course, COVID-19 in itself as a disease and SARS-CoV-2 as a virus do not need any references or introductions. So with that, we see significant pressures in radiology departments for those reporting, reviewing, and turnaround times. And so such a system, with its offering of assistive diagnosis in far reduced time, is able to make a difference. And of course, we do see more widely that workforce attrition or reduction in terms of radiology, and also some in-country aspects. So, for example, in the UK, there has been at least one study documenting that later diagnosis has been a contributing factor, or has been associated with higher mortality rates than the rest of Europe. So here we will go just a little bit into the literature, but from a practical viewpoint, in essence. So these are key aspects as documented in the work of Rogers, who looked at the innovation adoption and how it tends to happen. So the first aspect is trialability. So we need to ask ourselves, how easy can we make it for healthcare professionals to trial our technology, our offering, with minimal commitment and indeed investment? So do we make it easy for them, or not as much, perhaps? The second aspect is the advantage. in any opportunity, such as the adoption of the technology, there are risks and rewards. So do we explain them rather well? Are they understanding? Are they being our stakeholders within the healthcare organization, the healthcare environment? In terms of its compatibility, we also need to ask the question, and that is often a dialogue in essence, how compatible is it with existing structures, services, and even behaviors in the healthcare environment? Can we have an understanding of that compatibility, and what can we do in terms of our product development and enhancements to help with that? And then there's the observability. We are often asked the question, can we actually see it? What is biomind? Is it a robot? Is it a hand? Mechanical one? I mean, is it something else? And in our case, it's very clear. It is a clinical application suite. It runs on a server, so you will see it and get to use it on a screen. So it is very much a tangible computing reality of sorts, in essence, very much similar to what we're used to every day. And with that being the key aspect for us as to how to approach the healthcare environment and talk about that generation of evidence, the key question that we'll always have to contend with is coming from the healthcare professional, and some of the most senior is, okay, I see your materials, your presentation, I understand what your technology can do. My question is, what can it do for me? In my environment, for my staff, and very much importantly, for my patients. And it is when that question is asked that we can begin a fruitful dialogue with the healthcare professionals towards generating that evidence and thinking about the future state in terms of how they often occur in their environment. This is perhaps a summary of the journey of the innovation, adoption, and diffusion, in essence. You will see the different categories of adopters. You have the innovators, those that will readily embrace a new technology and will try and work with it in generating the evidence. Then we have the early adopters. Beyond that, there's then the adoption by the early majority and the late majority, and finally the laggards. Now, in each of these groups, we typically observe different behaviors. So the innovators and the early adopters tend to be quite enthusiastic. They will readily embrace it. They will see the benefits perhaps before anyone else. The more we move up the curve, the more as a commercial entity, so as a company, thank you. So the more we move up the curve, the more we need to be ready as a company, as a commercial entity, to offer a fuller service. And then we have to think about how we strengthen our relationship with our new and future customers in terms of the service we offer. And of course, you will see that while the adoption curve is a bell-shaped curve, so it tends to tail off, as it begins to tail off, your market share is increasing. So it is often helpful to look at these two curves in tandem. So in our industry, we often hear about the key opinion leaders, the so-called KOLs, but this isn't the only individual, in essence, or the only one role we would need to be approaching for that adoption to start taking place. There's the champion, and the champion is a very key role in the process. So while your key opinion leader will be quite senior, high influence, as an individual, and they will tend to be convinced by that hard evidence to be generated, your champion will be a step ahead. They will tend to see the benefits from the start. They will tend to visualize the impact in the healthcare environment. And then they will work with you to realize those benefits, to generate the evidence, to make that happen, to arrive at that future state for which they're ready to spend time with you in defining it. And I'm very pleased to say, by the way, that here in Luxembourg, in our clinical partner, we have one individual who happens to be the head of the radiology group at Hôpital Robert Schumann, who is acting both as a KOL and indeed a champion. And it's often very helpful to have both in one, because they can take a look at the hard evidence, the science-based evidence, and define next steps with us and with you as to how the technology is to be adopted. Of course, a key piece is stakeholder management. And here we have to think more widely and beyond any individual healthcare environment that we might be targeting as an evidence generation site or a future customer. So we have to have an ecosystem view. So we need to identify our stakeholders and then meet with them in their own time regularly on a one-to-one, as well as in project mode. So once a project is set up and it's up and running. Important is as well to highlight the benefits, the rewards and the risks to them. And those may be appreciated, perceived at the personal level, so with regards to their role, but there will be benefits for the organization. So one example in our case is that reduction in terms of scan reporting turnaround times. The future state is quite important. We will talk about that on the next slide and the principles we tend to apply. And then the usual good professional etiquette. So be there on time, send updates with regular frequency, and work with them in a consensual way to understand their requirements. Indeed, it has been shown in the literature that the promotion of that consensus among the players and stakeholders in a healthcare environment leads to that robust requirements gathering process and supports that. I would go as far as to say that healthcare isn't really the field or sector for any conflictual predisposition. We are all there for the benefit of patients. We have to find the consensus and design the future state in that way, on that basis. So, in terms of requirements gathering, we think of that as follows. So there will be the technology. It has to be adopted, embedded. So there will be a future state. And actually, when we come to see and think about what we hear in terms of opportunities for wider use in a particular hospital, the opportunities tend to come from linking up BioMind, in this case, with other hospital systems. So PACS is the main example. So once we achieve that seamless integration between the picture archive and communication system, the system that stores the images in a hospital, and our AI solution, then that's one step ahead in terms of, and further, in terms of designing that future state workflow. Here are some of our key stakeholders in essence. There are the clinicians, the nurses, the researchers, the IT staff, very important. They can provide with you with all the knowledge you need about, in effect, installing your system in the hospital. And we also have to think hard sometimes about the regulatory compliance and the ethics, particularly with AI, which that tends to be still quite new. And I mean, I often personally found that the more intellectually fruitful debate is about the ethics of using our solution and enhancing it in each of the healthcare systems we are in by now. So at the same time, because it is a multi-stakeholder context, we need to be using plain language, really. I think specialist terms will be there, and of course we have to, in effect, base our exchanges on expert language, but it often helps when we simplify the things and the tasks for everyone, and that keeps us moving forward more smoothly. Also to mention as well that because it is a multi-stakeholder context, you will see that different specialisms in the healthcare environment tend to appreciate and understand and then use different types of evidence. So while clinicians will be interested and will action the science-based evidence, so for example, the results of a randomized controlled trial or the report of a local trial, other specialisms, so nurses and non-clinical managers and others will be interested in other evidence, so expert opinion, the opinion of colleagues, patient feedback, very importantly. So whilst we tend to, in effect, focus on hard evidence, science-led evidence, these other types of evidence are equally important for the acceptance and the adoption of the technology. So we aim for workflow integration, and this is really the 2B. So once we adopt once we have the technology adopted, what is the future state? And in this regard, there are two key principles we tend to base ourselves. One is economy, and the other one is security. Why economy? Because I think we all understand that healthcare systems around the world are indeed facing pressures cost-wise. So we have to be able to show an interest in that and use and reuse IT and other equipment that might be available. Security is, of course, another topic. Information governance is a very important aspect of managing data in any healthcare system in Europe, the UK, and indeed around the world. And so the security of the data comes first, and then beyond that, the secure use, the safe use of the system for practitioners and patients is also key. So with security, let me add the safety as well, which is, of course, a key objective of any clinical trial. So it has to be, in effect, understood as part of security. Then there are some other best practices, as you see. So we do design the to-be state in order to minimize risk for patient safety and practitioner safety. We typically keep with system diversity, resilience, security in IT terms, and scalability. So allow the system once live in the hospital to automatically scale so that we do not have any interruption in terms of the service we offer. Another important aspect is the planning, in essence. I mean, when we approach a healthcare environment, a healthcare organization, our technology and its adoption is at the forefront of our minds. That's fair, but we do have to remember that there are other projects, other programs going on in that environment, particularly in large hospitals. So you may have larger systems that are being phased in, and indeed other priorities for the IT and other groups within the hospital. So there has to be that understanding that we have to work together in an agenda that might be more pluralistic than singular. And so, again, the consensus, quite key in terms of promoting that robust requirements gathering where everyone has a say in defining that future state in terms of the workflow and the everyday working reality in high pressurized environments. The results. So, simple question in business terms, what does good look like in this activity? And I think that excellence can indeed be exemplified by published studies on the evidence of your technology, the proven value add, and that stakeholder consensus where everyone understands and are indeed aligned towards the change that is about to take place by adopting and having your technology more widely diffused even in the healthcare system. And for us, we have been able to move towards that direction in the following ways. We have had a positive expert opinion by the European Society of Radiology. We have had some peer-reviewed publications already, including a Lancet preprint and one in Frontiers in Informatics for the stroke module. We have had regulatory approval in the EU via TÜV Rheinland in Germany, and through the MHRA in the UK, the Medicines and Healthcare Products Regulatory Agency. And very interestingly and very excitedly so, we have completed a pilot validation not very far from Luxembourg, in Mainz, in nearby Germany. And we have one ongoing, even more exciting in essence, because the sample there is far greater. And of course, London, as a very big metropolitan center, has higher prevalence in terms of brain tumor. So that study is ongoing at UCLH, at University College London Hospitals. Here in Luxembourg, we have had a very good example of how the system can be used. The COVID-19 module has been used as a consultative tool by Hôpitaux Robert Schumann, the radiology group, during the COVID-19 crisis. And we have been able to see for ourselves that by taking a few simple steps in terms of IT and making the system available, for example, while clinicians work from home, we were able to offer that second opinion to the radiologists reviewing CT scans of patients. Now that in itself is indeed very valuable as a contribution. And the journey is of course ongoing, and I'm sure Carole will say we have huge work in front of us. The next slide is just a collage of what we have been able to put together and in place. We're particularly thankful for the support of the ministry and indeed Lux Innovation in Luxembourg. Hôpitaux Robert Schumann, here you see one of our webinars last year for the use cases for the system in European hospitals with Dr. Jean-Baptiste Niederkorn and our experts from Singapore and China. The publication, that's the paper in Frontiers in Informatics, and before the pandemic started, our RSNA presentation together with Hôpitaux Robert Schumann. Many thanks. Thank you, Carole. Okay. So, my apologies, I seem to have taken a bit more time. Is there any question that you would like to ask? Not that I can see, the lights are just a bit bright, but is there any question from the audience that I may not be seeing? So, no, okay.
Thank you so much. Thank you so much, Kyriakos. I'm sorry we didn't have a longer slot. I know there's many war stories to tell. Thank you so much. I would like us to take us to our next expert. He's been waiting patiently for us online. His role with All Health is developing clinical partnerships across the globe with payers, providers, regulators at driving population scale for integrated continuous monitoring. The platform bridges the gap from a transition from a fee-for-service for fee-for-value model. His presentation is dedicated to global health tech search and the golden opportunity for transition to Care 0.20. Please give a warm welcome to Dr. Borzo Baradari, who is connecting with us right now. Borzo, you're there. Wonderful. I hand over to you. Good luck. Thank you.
Thank you. Thank you, Carole. And thank you all for staying on. I know it's late afternoon. I'm calling out of Dubai. Wasn't able to be in Luxembourg, but here we go, the new word. So my name is Borzo Baradari. I'm the VP of Global Clinical Services for All Health. And I'll be discussing the global tech search and the golden opportunity to transition to Care 2.0. A little bit about myself. As Carole already mentioned, I'm actually from Luxembourg and did my clinical training in London and left the NHS for greener pastures, ended up doing some strategy work, and then ended up joining the Cleveland Clinic in their Greenfield project in Abu Dhabi in order to gain more operational experience and to understand what the challenges are in health systems and in hospitals. And ultimately, towards the end, I ended up working a lot more around innovation right before COVID hit. And we were looking at finding startups that could help hospitals solve some of the challenges we've had, which we couldn't solve with legacy companies that were already part of the system. So we created an incubator within the hospital. COVID hit, we started doing a number of clinical trials. After COVID, I decided then to join one of these companies. So my perspective is really coming from someone who's been in clinical, then moved into strategy, more high level within the Middle East, and then a lot of operational experience, spent about 8.5 years with Cleveland. And then now with All Health, our company is based out of San Francisco. We have an office in London. We opened an office here in the UAE. We're looking at opportunities in Luxembourg as well. And as the previous speaker said, we are also in discussions with Hôpital Robert Schumann. They seem to be very active, which is great. So I'll get started. The presentation will really be around showing you 5 different forces that we, or I believe, are creating an opportune moment for health systems and hospitals to jump into the next wave of health tech that's coming. Now, everything really starts nowadays with COVID, and from a health tech perspective, really, there's been a silver lining coming out of the pandemic, and I'll go through that in a bit. But the pandemic has really surfaced a lot of shortcomings of current health systems at a global scale, and which became very acute, right? So last year when I was in Cleveland, we saw a lot of patients coming through that. We saw a lot of patients coming through that had already preconditions, and that made the complications much worse. So we've had patients who were in their mid-30s and were in ICUs because they had diabetes, they had different heart conditions that weren't being addressed. So it was a reality check around, suboptimal health status / restricted access to healthcare. Although there's obviously significant amount of spending that has been going on, and I'm using here the example of the US, but it's similar in a lot of different places. Second of all, here we've seen a massive change in regulation and reimbursement. This was probably the biggest driver. And since the telehealth took off about a year ago in the midst of COVID in most countries and started stabilizing, we've still seen about a 38x increase in growth of telehealth over time. The CMS, which is the Center for Medicaid and Medicare Services, they oversee about $800 billion of healthcare spending in the US, have again extended their telehealth codes for 2021. And as of about a month ago, they added 18 new services that are now, again, temporarily approved for virtual care. So it starts, shaping the direction that we're going. Obviously, the US is, heavily at the head of the spear on this. The second or third really driving force is this aging demographic that is driving up costs even more. And what I mean with aging demographic is the share of 65-year-old plus. In the US, what we're seeing is it stands currently at about 17% of their total population, which will grow to close to 22%. At the same time, the percent of GDP spent on healthcare in the US, according to many, is completely unsustainable at about also 70%, increasing, and that represents about a $3 trillion spend on an annual basis. The other countries in Europe are a little bit lower, slightly lower. I believe Luxembourg is probably around 6 or 7% as well. So spending is just, increasing significantly. At the same time, you have a supply shortage from a physician perspective. In the US, we're estimating a shortage by 2030 over really the next 10 years of about close to 50 to 140,000 physicians. That's based on various models. That's why you see this big gap when physicians will retire, whether there be incentives for physicians to retire later than sooner, and going according to really traditional models of delivering healthcare. And coming back to the statement I made before around the silver lining, really from a pre-IPO investment perspective in health tech, last year and this year have really been record years. If you see here, back about 10 years ago, funding was about 2.1 billion pre-IPO for health tech. By 2020, it was tenfold. And obviously, this is when COVID started and a lot of companies started pushing more funding into it. This year, we're seeing we expect the funding to reach almost 38 billion, which is really an unreal amount of funding going into healthcare technologies. By June, there's been already 48 deals that were funded, so more to come by the end of the year. But this gives you really a picture of, we're talking about tech companies that are not bootstrapped with a budget of 100,000 euros or 500,000 euros. These are really companies that are gearing up to go against the big players in healthcare from a technology perspective. And this is what we're seeing. What is the innovation disruption? In which area is it happening? The EHR is really where we would call it the first wave of digitization in healthcare, where you moved from paper to digital. And that's been a very painful experience for a lot of health systems from a cost perspective, but also from an physician engagement and satisfaction perspective, because most EHRs have really lived very short of expectations on that front. So what we're seeing, and I'm using the example of Epic, because Epic is one of the largest ones, at least in the US and global. They have about 250 million American medical records, and they control about 30% of the market share on hospital EHRs. So you could see that where it started with telehealth, there's 10 really different areas that are being carved out by smaller startups that are trying to deliver a better experience on the provider side, better experience on the patient side, better outcomes, as well as reduce cost. And for those who know Epic, it's not a very cheap offering that's out there. So this is really to give you the picture of where the attack is happening all at the same time, really. Now, to step back for a second and just to take you to another industry where something similar, from my perspective, has happened, is the telecom and the music industry. For those of you who are old enough, you remember what a Discman was, or a Walkman, or a mini disc, or the boombox, VHS recorders. I don't think our kids will ever know what those are, or these bulky mobile phones. All of these, we don't use most of these anymore. Maybe the TV, some maybe still use a desktop, but most of these have really been dematerialized, what we call it, and miniaturized into one smartphone. A smartphone that now has more processing power than any of these or a combination of these before. It provides a lot more capability and features, and it's opened up a lot of access. We see something similar happening on the healthcare side because of the pandemic. So remote care being led by teleconsultations is not enough, because you're missing the data element for the physicians to make good decisions on patient management. So remote care, remote patient monitoring has really taken off from what we've seen in different countries around the world. In the US, the codes around RPMs have been taken off. Again, because patients don't want to come in, or hospitals are realizing we need to really focus on being able to manage these patients remotely. The current system, however, with bulky medical devices, makes it very difficult. One, it's bulky, expensive, and it's not really scalable. So this is probably an older model, but you have now the Bluetooth-enabled blood pressure cuffs, thermometers, home sleep apnea devices, EKGs, pulse oximetries, and glucose monitors. These are just an example that I put together. But the idea is you as a physician or as a care team prescribe a number of these for patients. And at best, what you're going to get is, if they remember to use those, you will get data as a care team. So it's very episodic data. And what we think is happening is in process of happening is a lot of these will be miniaturized as well. And they will be moved into smaller devices such as wearables. Now, why is that important? Because that addresses some of the challenges of the system around accessibility. Healthcare access is a topic of every hospital that you go to, at least at the leadership level, and similarly from a health system perspective. So miniaturizing this makes it available to more people, as well as the affordability element. The unit cost of these devices is significantly lower than some of these. You're able to start getting continuous data, which will start giving you a very different picture around the health status of the patient versus episodic data. And from some of the work we've done in Dubai around diabetes management, we've seen a significant difference around impacting behavior change on patients, especially around chronic diseases. And what we also found is there's elements of care team efficiencies that you can bring. And with that, we mean panel size increases. So physicians being able, or care teams being able to manage a lot more patients than through traditional models. So ultimately, this kind of a shift that we believe is already happening will drive towards a more accessible and exponentially scalable remote monitoring. Then you have a second layer, because these devices will start giving all of this data out. The question is, who's going to look at it? You don't expect human beings to go through raw data. So what you need are very sophisticated AI models that will be able to provide action-driven insights to care teams. And we see that happening. This is just a short timeline from 2014 to about 2019 here on FDA approvals for algorithms, specifically in different specialties: cardiology, psychiatry, radiology obviously has a lot, as the previous speaker was already mentioning on that topic. And what we see is the takeaways from this is because these are getting regulated now, and we've seen about 46 FDA approvals since 2014 in the US alone, this will lead towards reimbursement. Once this leads to reimbursement, it means your unit cost per diagnosis is going to be a fraction of a physician and faster, again, as the previous speaker has mentioned. So this brings a level of affordability and, again, accessibility, moving towards a more on-demand, remote, and highly scalable system. Healthcare, we have to realize that, and these are conversations we had in the hospital last year, was we are one of the only industries that has been lagging this on-demand, remote kind of model, which a lot of the other industries have already embraced. So this is, we believe, going to be very significant. And what this really leads to is, yes,
you're in the last 2 minutes. Could you wrap up, please, so that we can start the round table on time? Thank you.
Sure, no problem. Almost there. So what this leads us to is really moving towards a more proactive and prevention model. Currently, most people don't spend more than 60 minutes with their care team per year. So you're missing out on a lot of data points that could help you change behaviors or nudge behaviors. This is something, again, as I said, we've seen a lot on with our pilot in Dubai around diabetes management. And this is just a summary slide around the 5 forces. So regulatory reimbursement, substandard kind of chronic disease management, and limited healthcare access, aging demographic driving up the cost, and then clinical workforce shortages, being faced with a supply of very well-funded health tech companies. And this will enable, especially single payer systems, to move towards to bridge that element of moving into a proactive approach of treating patients and driving down costs. There we are. Back to you, Carole.
Thank you so much. Thank you for being with us so far. And we're not done with you. We are now expanding the round to the roundtable discussion, where we will talk about doctors as innovators, co-innovators. To do so, I would like to invite our moderator, Suzanne Vandewengen, journalist at Let's Be Healthy. While she's coming up, I would also like to invite our other panelist, Dr. Michael Witsch, who is Chief Digital Medical Officer at the Centre Hospitalier in Luxembourg. Together with Bodyo, they will take you to the discussion of doctors as co-innovators. Thank you so much. Over to you.
So hello everyone, hello to you too. So please have a seat. I'm really glad to be here to moderate this roundtable, but of course, I'm going to let you both talk about digitalization and, of course, how does it impact on a daily basis, especially for you as a doctor and for you as an innovator. So please go on, and I will be there to direct a few questions. Or if you don't know what to say, you can just rely on me. I always know what to say. So who wants to talk first?
I'll let the gentleman get started. I already had my 10, 15 minutes of talking, so I'll take a small break.
Okay, hello, I'm Michael Witch. I'm a physician, I'm a pediatrician. And I started to create an electronic healthcare system 20 years ago because I was not able typing all the time with my hand. Nobody can read it. And the flow of information was so weak in our hospital that we need a stronger system to share information. And now, I moved 10 years ago to Luxembourg, and here I found in my diabetic department a way to integrate all these, what we have heard from you, in my daily work. I just came now 30 minutes ago from my consultation, and what do I do there? We have diabetic patients. They have their pumps and meters. They send the data all the time, not only occasional, in real time, the whole day, to their devices, to the cloud, and we can analyze them. When I see them on consultation, I can give them advices. How do they change the treatment opportunities, what they can do? And these modern technologies, they have algorithm in the insulin pump, for instance. They already know how much insulin they would give to the patient. And they control the blood sugar now during nighttime almost perfectly. So what we see is that the technology is not only, for nice slides, it's really in our daily business. And of course, as doctors, our role becomes more and more to accompany the patient in the best choice, because not all patients are fit for a lot of technologies. Some of them, adolescents, sometimes they don't like to wear something, on their body. They want to be free. So of course, we need the miniaturization of all these devices. They are sometimes even today too big. But there are many patients, they love it. Imagine parents with a 1-year-old child who has diabetes, checking 5 times a nighttime. Now the technology is taking over this, and it alerts the parents, and it also regulates the blood sugar, that there's no more real alert necessary. So that gives so much more quality of life for the patients, and also in my field for the parents. That is amazing what we can do now. We are talking about the radiology, and I work in the Centre Hospitalier. So I started now 5 years ago that my images for the bone age, there's a specific measurement which I need to not to control the age of a body. Younger bones are aging in the first years of life, and what we want is to have this information because we have diseases where it's retarded or where it's accelerated. And the technology is doing it perfectly. We use the radiologist as a control and to look at other aspects of the image, but this measurement of the bone age is done automatically today. So therefore, we have a huge help with the technology, but I have to admit, in many other aspects in our hospital, we are in Stone Age. Because what I do, I have perfect systems who do a single task, but the transfer of information from one system to the next system is often human by me. So I write down, the result of this bone age in my health record. So there's a huge workload in the next year that these information become really fluently, that we have a real digitalization, and that we can work with this data. Because what we do in my hospital, I told you that we start having all the data from the patient, but now we do benchmarking with it. We compare ourselves twice a year with over 150 centers worldwide, even with huge universities in the US and Canada, also in your area, and we look where's the best in class and what was his model to become better. So we share this data to improve the outcome of our patient, because you can imagine in diabetes, 20 years of a bad control means you have tremendous consequences for the patient. You know, the renal insufficiency, you have heart attacks, you have a lot of problems. But when you treat them from the beginning well, they have almost the same life expectancy that a patient without diabetes. And that's so, you know, that gives us also so much hope that when we use the technology right and we overcome the burden of using it in a regular way, that means, you know, becoming more smaller, more user-friendly, then really we can help our patients. And we want to learn from this data to make our daily business much better. And we share this data in our team. It's not only the physician. We discuss it weekly with our nurses, with the psychologist, with the dietitian. So the whole team is in this process also of feeding the system, not, you know, doing it twice, because it's so much work transferring data from one system to another. So what we try is integrate in one system all the data directly and get in output for the benchmarking and of course for our daily work with the patients. And just to end up, in the future, we will integrate also automatic help. We have a colleague in the Netherlands. He has created a system where the patient already receives some messages. Hey, your blood sugar is quite high. Maybe you check. You can say, okay, that's embarrassing. I don't want to be, you know, just out for a meal, dinner with friends, and my iPhone is telling me, hey, Michael, you have to do something for your health. But it will be the future. You see it in your cars, and of course, we will see it also for chronic diseases. That of course you can use it. And you can say, no, that's not my business to use this technology, but it can help tremendously.
So both from your perspective, now that you heard Michael, would you say he's a customer? Do you listen to other people like him saying, I need this to create better healthcare?
Yes, so what Dr. Witch said was resonating a lot with me. I think we should actually talk offline as well, because what we've done really with the case study here in Dubai with the diabetes clinic was we help. So we power the clinic from an infrastructure and tech perspective, and we integrate all of the different elements that Dr. Witch was talking about from a data perspective. So you have the EHR that we've integrated in. We have surveys that go to the patient via the app that come back to the platform. We have all of the devices, so from continuous glucose monitor, basic glucose monitor, blood pressure cuffs, weighted scales, everything is integrated within the platform. So what we've realized is this is how we started the model about 8 months ago. And obviously we're working very closely with the clinical team, from coaches, nurses, pharmacists, nutritionists, diabetes educator to physician. And what we realized is, as Dr. Witch was saying, we're trying to eliminate completely duplication of effort from a care team side. So we don't want them to, if they've already typed it in the EHR, we don't want them to go and copy paste it onto our platform or onto another Excel file. So what we've done is for their staff meetings, for instance, where they go over the patients one by one, usually a lot of hospitals or clinics use Excel files. What we've done is we've integrated and digitalized all of that into the platform in a much more user-friendly way. Now, it's not just the element of digitization, but it's also looking at every intervention. We're trying to look at it from the moment you come into the clinic and you register for the program to the time you get health outcomes, improved health outcomes around your HbA1c, which is something we've been able to show in Dubai. At least in over a 3-month period, we've shown a reduction of 1.7% on HbA1c, which is very significant compared to a lot of the competitors we have in the US. But at the same time, we're trying to figure out in that gray zone in between, where you're not in the clinic and the data is coming in, what is the interaction between the care team, whether it's the coach or the physician or the nurse or the pharmacist, and what is the biomarker change on that patient? Is the patient responding to that communication that comes via the app from the coach or from another care team member or not? So this is the level of, we're starting to look at a very micro level to see if we can achieve micro changes in behavior. Because ultimately the reality is you're not going to have an overnight change in behavior, whether it's diabetes or most other conditions. So we're trying to figure out by providing visibility into how these care pathways are really linked. So to answer your question, we are in almost daily conversations with the clinical team. So whether it's the physician or the coaches, we're there to support them, and we're trying to learn how they function and how can we save more time for them so they can spend the time on quality patient interaction. Because the quality patient interaction is something that the machine will never really replace, or at least not in the medium term. And to what Dr. Witch was saying, so Smart Coach is something that we're using where, you know, if someone's glucose levels have gone out of range, you want an automatic nudge. You don't necessarily need a human being to be sitting behind the machine and saying, okay, if this person has just eaten a Kit Kat and the levels have gone out of control, someone needs to let that patient know. What we've also started doing, we're bringing in an element of education. Because what you realize is patients don't always know what healthy food means. And food is obviously a huge element in terms of managing your blood glucose levels. So we have a food logging element on the platform where the nutritionists encourage the patients to take a picture and upload it on the app. What that does is we provide them an overlay of their glucose measurements versus what food they had. So patients are starting to realize, oh, the bread that I thought is brown bread and that was supposed to be healthy is spiking my sugar levels every time I eat it. So maybe I shouldn't eat this type of bread. So there's that education element to it. And what we're going into now more is really a stress management element. Because obviously, you know, life is not linear. There's a lot of different stress elements that activate cortisol levels that make it more difficult for patients to manage their blood sugar levels. So we're looking at social elements, family elements, career elements. We have coaches that interact with patients to advise them on breath work, advise them on activity, on sleep hygiene. So really a very much holistic approach to try and move the patient towards a more healthier behavior and to reach goals that are really realistic and not just ask them to go from 3,000 steps to 10,000 steps overnight and then have them be really, disappointed.
So would you say that digitalization is also an educational problem? Because when we hear about digitalization, we also hear people saying, yes, but a machine cannot replace a human. So how do you two deal with this fear of AIs and new technologies? Because this is today a reality. And so this will be our last question because we need to wrap things up quickly in like 5 minutes. So please go on.
When I start?
Should I go first? You want to go first, Dr. Witch?
Yeah, okay, I'll start. You know, I think the most convincing argument is try it. I have a lot of parents, they don't trust the technology at the beginning. Because I said, now a pump with an algorithm is giving insulin, which can be deadly. Too much insulin can mean, okay, I harm my child. A 2-year-old child is lying in your bed. And then we say, yes, we do studies in our hospital that shows it works. And then they see the results, and then they were so convinced. Some mothers sleep for the first time after 5 years. They slept the first time a whole night because technology was taking over the care for a child. Of course, we have to have this in mind that, you know, there can be an accident. I will not say that the machines are 100% perfect, but we have a lot more human problems, giving too much insulin, two parents thinking, I was giving the insulin shot in the evening, and both of them gave insulin, and some hours later they realized the child has a severe hypoglycemia. This will not happen with a pump which has an algorithm in it. So what we see is they try it and they're totally convinced. With the newest technologies, they are really very convinced. And then they spoke to other parents. And then the other parents, oh, mate, I've tried. And then we say, you don't have to take it. You have a 4-week period, try it. And when you think, yes, that's a technology for me, I want really to stay on it, then we give it and then we prescribe it. We are not convincing them you have to do it. We have patients that do not like technology at all. And I say, hey, when you want to try it, and some of them coming years later, now it's the moment to try it. And I think that's the most convincing argument is not, you know, the knowledge about, you know, everything will be better. This is for adolescents. They don't care about my words. They want to see, okay, is it really life-changing for me? Has it a benefit? And then they are convinced. And I think that is most that we look really on the need of our patients. You're not convinced with your telephone when it doesn't give you good apps and when it doesn't work fluidly. But when you think, wow, it works perfectly, then you try it. When you stay in your car and you see, oh, he's really helping when I'm tired, he awakes me, then I say, I trust this technology. And I think it's stepwise. It's not from total control or from no control to total control. It's a process to more and more control. And what we have heard now, of course, do we want that the machine is telling me this food is not good for you? That's a decision. And there were some patients who will never allow this, that the machine is taking over, you know, the choice of my meal. But others will say, okay, maybe I should try it because at the end I will live 10 years longer and maybe the other bread is not so bad at all. So I think there's, for me, there is a lot of opportunity. What we need is good teams that can explain and not only use it, try it, and without good explanations. You need a lot of education around these new technologies that the patients really can accept it and that they feel secure because the team is giving also this security. No, we will accompany you with this technology.
Okay, Bozo, a few words before we wrap this up?
Yeah. Sure. I mean, I agree with everything Dr. Witch has said, but just to add on, in our case, we have the physicians use the technologies themselves. So most of the care team is using it. So that brings an element of trust. Of course, you're always going to have patients who are going to be very suspicious around the technology. But the benefit with AI and these models is really, it's ultimately about data, right? And for a lot of people, it's difficult to ignore data. And when they start seeing the changes, so when we bring patients back for their 3-month follow-ups, the physician sits in the consultation and shows a big screen around the graphs, literally. They go through our platform and show them, this was your weight, this is how your weight has been changing, this is how your blood sugar levels have been changing, this is how your sleep, activity, food patterns have been changing. So it starts building more and more trust with the patient. And I think, you know, AI models are not perfect right now, and probably they won't ever be. But you also have to look at the access to data that's available currently to build these models. I think these models will become significantly better in the future. And ultimately, you want care teams to be able to practice at the top of their license, whether it's a physician or a nurse or a pharmacist. There's a lot of pattern work that is happening currently in hospital settings, in clinic settings. And that becomes very monotonous, right? If you can have an algorithm take that over, specifically the pattern work, it saves a lot of time and it brings a lot more engagement and satisfaction, not just to the patient, but also to the care team. I think it's a two-way street.
Thank you very much. I'm sorry we have to conclude this roundtable. Thank you both for being with us. And hopefully you can discuss offline now.
Absolutely.
Thank you.
We will.
For sure. For sure.
Thank you very much.
Thank you. Just give it to the organizer. Thank you so much for this inspiring discussion. Now, we're on to the last speaker, And by far the least, I'd like to introduce you to a shoulder, elbow, wrist and hand surgeon, professor at Paris-Sorbonne University, chief of department at the teaching hospital Bobigny, Hôpitaux de Paris. He is one of the first surgeons who's in 2017 performed the first surgery in augmented reality. And today he will present us from mixed reality to artificial intelligence guided surgery, an example in shoulder and hand surgery. Please give a warm welcome to Professor Thomas Grégory. Over to you, Professor. Thank you.
Hello, thank you. Thank you very much for your very nice and kind invitation. I'm really glad to give this keynote. And I'm sure the day was very, very busy, so I will try to be as quick as possible and to go right to the point. So let's go directly to the presentation. Yes. So yes, I'm a professor of orthopedic surgery in Paris area at the University Sorbonne Paris Nord, and I'm chief of department of an orthopedic department that is expert in upper limb surgery, shoulder, elbow, wrist, hand surgery. We are the referral university center for the north of Paris and Paris area. But beyond that, with one of my friends and colleagues, Professor Benani, a very well-known mathematician and expert in artificial intelligence, we created 1 year ago research center dedicated to artificial intelligence guided surgery. So I will try to explain how we came from mixed reality to artificial intelligence guided surgery, of course, in my area of expertise. So we all know that we are all facing the third revolution, the revolution of information and communication. So as all industrial revolution, it has not a linear trend, but it has an exponential trend with a booster. And the first booster was probably in the 1980s, a computer for everybody, so miniaturization of computer. A second booster was, of course, HoloLens in 2000. The third booster was, of course, the smartphone in 2017. And now the booster of this revolution, this digital revolution, is the artificial intelligence. And we all know how internet, computer, of course, smartphone has dramatically transformed our daily lives. And we will see how artificial intelligence will also completely transform our daily life. And where are we in this revolution of information and communication? Still probably at the beginning. So it's very exciting. It's also very exciting when you're a professor of medicine, because it is completely transforming also medicine. And if you want to figure out how this digital revolution is transforming currently medicine, with Professor Benani, we propose this classification in 5 areas. You've got the personalized care, so a treatment for each individual. You've got, of course, telemedicine with all its subgroups, teleclinic, telemonitoring, tele-expertise, teleassistance. You've got training and simulation. And in surgery, it's never the first time on a patient. And I'm sure it makes sense for you, because what is experience for surgeons? Experience is just learning from mistakes. So I'm sure that none of you wants to be the patient on who the surgeon failed to become better. So simulation is a big area. You've got the augmented patient, and for us, upper limb surgeon is the bionic hand, the hand of Star Wars, Luke Skywalker, but this is no more future. There are a lot of initiative, and we are quite close from that. But today we will talk about the augmented surgeon. So what is the augmented surgeon? It's the surgeons that who have his sense, his skill, improved by the technology to become better, more accurate in his gesture, but also to ensure security of the surgery. So in the portfolio of the augmented surgeons, so far we have navigation, 3D printing, robotic, and today mixed reality is, I believe, in the portfolio of the augmented orthopedic surgeon. So what is mixed reality? This concept was launched by Microsoft a couple of years ago with its HoloLens. So what is a HoloLens? It's a headset with two cameras. In fact, it's not just a headset, it's a real computer. And this computer has an artificial intelligence sensor. So instead of interacting with your computer with a keyboard or a mouse, you interact with your HoloLens through oral command or gesture understood by the camera and processed by artificial intelligence sensor. So the HoloLens is also equipped with a mapping sensor. So the HoloLens understands where the environment is in real time. So the system is able to contour the floor, the ceiling, the walls, etc. So it can place 3D virtual elements, i.e. holograms, in the real environment. So that's why it's called so-called mixed reality. But besides that, HoloLens is a real computer. So it has all the functionality of a real computer with Wi-Fi and Bluetooth and mixed reality apps. So as you can see on the video, in December 2017, we used for the first time the HoloLens for shoulder arthroplasty. And yes, it was a world premiere. While I was operating, I had access to the 3D reconstruction of the patient anatomy, to the tech op in an holographic mode, to the surgical planning in 3D. And I was also remotely assisted by surgeons from US, UK, and South Korea. So we realized by that time, so in 2017, the huge potential of HoloLens in surgery. But in this first version with the HoloLens 1, and we know that we are now at the iPhone 13, almost 13, but in 2017 we had the HoloLens only 1, so the technology was probably not good enough, and especially the artificial intelligence sensor were not good enough to use HoloLens in routine practice. So since then, Microsoft launched the HoloLens 2. So it's a new version of HoloLens, and the artificial intelligence sensors are really much better. And with this version, the interaction with the holograms and apps are much more fluid and we organize. Therefore, with Microsoft, Evolutis, and my university last February 2021, an event during which, during 24 hours, surgeons from 13 countries used the HoloLens during orthopedic surgery, mainly, of course, upper limb surgery, connected to a control tower located in Paris, in the University Sorbonne Paris Nord. So the purpose of this event was to demonstrate that the technology can be used anywhere, and nowadays I use HoloLens in routine practice in my department with all my colleagues. So the question is then, is the technology going to be accepted in surgery? And it's quite interesting to analyze, to refer to this publication of the Lancet. You all know, I guess, the Lancet journal, one of the biggest medical journal. So this publication of the Lancet about the factors that drive adoption of innovation in surgery. And if you analyze carefully and read carefully this article, you realize that mixed reality meets all the requirements. First, it is well known that the need for technology is well perceived and therefore encouraged by patients. And I think this is the most important, is the perception of patient of technology. Second, in March 2021, Microsoft won a nearly $22 billion contract with the US Army to produce custom HoloLens headsets. So you can therefore realize that the HoloLens will be developed further with next generation, HoloLens 3, 4, and perhaps one day 13. And all these new versions will be much more effective. So third, mixed reality is a relatively cheap technology, and it's very important for the democratization of the use of technology in surgery. A HoloLens costs approximately 3,500 euros. So you can say, yes, it's relatively expensive, but in fact, it's affordable by any hospital in Europe or even in the world. And if you compare the 3,500 euros of the HoloLens with the million euros of a robot, you can realize that this is a tool that could really democratize a technology in surgery. So then the perception of this technology by surgeons, it is also very good. After our 24-hour event of holographic surgery, we ran a survey to collect surgeons' perception on this technology. And what is really, really incredible is to analyze the fact that all the surgeons were satisfied or very satisfied. And 95% of them declare that they are prone to continue to use mixed reality in their practice. So another interesting point is if you analyze PubMed, I'm sure most of you are familiar with PubMed. It's a research program on internet to look for all the medical publication. So the interest of medical research on mixed reality in surgery is following an exponential trend. And with now 345 publications last year about mixed reality and surgery, it follows, in fact, the same trend with a gap of 30 years than arthroscopy. So arthroscopy nowadays a very basic and routine device in surgery, and you can foresee that mixed reality will be used in a couple of years as routinely as arthroscopy is used nowadays. So what about the benefit of the mixed reality in our current practice? And in our survey following the 24-hour of holographic surgery event, to the question which mixed reality function was found the most useful, the surgeon answered first, the capacity of the device to facilitate discussion and feedback with colleagues. Then the access to the pre-op data of the patient, but then during the surgery. And at last, the capacity to get access to the pre-op planning. And today, the first benefit of this technology is to use it by connecting the system to a Microsoft Teams meeting to share information with colleagues in order to perform live surgery, but also tele-expertise, tele-assistance, to train and to help juniors or to do tele-expertise with other colleagues, for instance, oncologists, radiotherapists, if you operate on a tumor. Another benefit of this technology is then the ability for the surgeon to access a computer during the surgery and consequently to connect with all the application he usually used before the surgery. He has access to, in fact, the patient notes, the packs where are located all the patient imaging, the operative technique, to any model created before the surgery. He is also able to shoot photos and video and to transfer them to secure OneDrive in order to share all these elements with the patient him or herself or with colleagues. So you can see on this video, I will try to open all the video at the same times. It's not going to be too bloody. You can see on this video how the HoloLens can be used and how HoloLens is used nowadays as a routine tool in my surgical department for all these purposes. So, what is the future? In fact, it's not really the future, it's the present, because lots of research is performed and we have innovation every single month about creation of new applications for the use of mixed reality in surgery. So can we use mixed reality as a cheap navigation system for shoulder arthroplasty? Cheap does not mean not accurate. Of course, it's cheap and very accurate, but cheap means a tool that could democratize navigation in all the theaters. To that, you can import in the system pre-op planning and in 3D from dedicated planning software or from open source software. And you can manually grab the hologram so that the visible part of the bone fits with the corresponding part of the hologram. However, lots of research are currently being performed to incorporate mixed reality to traditional navigation system or to use a system with QR codes. And with the next generation of HoloLens, with a much more precise mapping sensor of the HoloLens itself, it will be a piece of cake to use the HoloLens by them own to navigate in patient and to make the invisible visible. The invisible, it's what is beyond the skin of the patient. And of course, the goal for the surgeon is to be able to see through the skin of the surgeons, the bones, the muscles, the artery, and the nerve. And we are now sure that with the next generation of HoloLens, it's going to be gradually much more easy, and then our dreams going to become true. Just to show you a new useful application, and I'm sure you will understand how this application is useful after this COVID-19 pandemic. And now we are the capacity with the HoloLens to create some stuff, some meeting through avatars. So it's also like you know, the film Avatar or the communication in Star Wars with Avatar. So it's the capacity to use the system to perform holographic avatar meeting, and you can see on this video how it is used, you know, to interact. So the two participants are virtually in the same room, and they were able to share data in 3D or 2D and to see the avatar of each other, but each one was in his own location. Jonathan was in the south of France, and I was in Paris, but virtually we were in the same room. So now we're going to talk about artificial intelligence guided surgery. And I believe that HoloLens are an important tool for the future of technology in surgery, because it is the tool that will allow artificial intelligence guided surgery. So what it is, artificial intelligence guided surgery? The mixed reality, the HoloLens, with its camera, with its eye tracking, with its microphone, is able to capture thousands of data of surgery and surgeon. And all this data, if processed by artificial intelligence algorithm and transcribed to the surgeons in the headset itself, will give a guiding element to the surgeon to perform even more personalized surgery. In a career, you get some more experience. You get some more experience with all the patients you operated on. You encounter some, anatomic variation, and all this experience, it's your own experience. You try to share it with colleagues, but still it's a limited experience. And even in the life of one top surgeon, he will not be able to observe all the anatomical variation or all the case. But if all these experience of surgeons are processed in an artificial intelligence sensor, it will give the surgeons a fantastic tools, and it will, beyond that, provide for the patient itself a fantastic security tool for the success of its surgery. So sorry for this also image. It's a cadaveric dissection of her hand. And I just want to show you one of the work we did in our research department. So an artificial intelligence algorithm in the HoloLens is able to detect what is a tendon, what is an artery, what is muscles, what is nerve. And it was quite easy to do that. And now we are training this algorithm to learn how to detect injuries of this tendon or nerve or artery. So you can imagine with the HoloLens, you can visualize the operative field, and the artificial algorithm will be able to detect what is an artery, if it's artery is injured or not, and beyond that, in a future, what is the best treatment for this lesion. So to conclude your day, mixed reality today is in the portfolio of the surgeons. It's going to be in the ecosystem, and it's a fantastic tool to transform surgery from computer-assisted surgery to artificial intelligence guided surgery. Thank you for your attention, and I'm very happy to answer questions.
Thank you, Professor Gregory. I think there's no questions, so thank you very much for this insightful presentation and giving us the opportunity to share your learnings. This concludes this afternoon. It also concludes the Digital Summit. Thank you so much for joining us today. Hopefully This will be the first of many. All that remains for me to say is also a round of thanks to all of you for being here, for sharing us and learning what there is to know about digital health. I would like to thank the organizers to have the faith in giving this topic a chance. I would like to thank our speakers for taking the time. And I would like to thank you for staying to the end and hearing what our speakers have to say, and hope to see you again next time. Thank you.